Oh, yes, someone's got
I'm missing a presenter, doctor.
Who are you missing? Sabrina. Let me find her. She's coming right up with it.
Yes, please. I mean, you see me walking around.
Our EV specialist. He said, I'm seeing a presentation.
It is.
Great.
That was difficult.
Patient Symposium slides. I don't know why it's a folder. It's just one thing. Thank you.
Well, as it's a bit past 8:30, I'd like to get started. We have a huge amount of thanks to the supporters of the symposium. This includes Bristol Myers Squibb, Iovance, Merck, Natera, and Pfizer, all of whom have exhibits outside. If you have questions, their representatives are there and happy to answer any questions you may have. I want to thank all of you for coming. I think 30 of you are here in person, but another 100 online. So we have questions that'll be taken after each of the talks. If you have a question, just flag us down. we'll have a microphone that we'll bring around for anybody here who has questions. Then we'll turn to online questions, and there it'll come in through the chat. And we have Parham again, who helped us last year. And thank you, Parham, for taking those and monitoring that this year as well. We've been doing this for 40 years. In the old days at Montefiore, when the Cancer Institute was the ground level of Montefiore, and since 2002 here, and for the last 11 years, AIMS really helped to integrate this and make it a national event. So we're really very glad for that. And I know Dr. Najar is on service and needs to make rounds, and we'll have to leave after her talk. So I think we'll turn immediately to Jana's talk. Thank you so much, Jana.
Good morning, everybody. Thank you so much for being here. Is Keith pulling them up? I'm one of the medical oncologists, part of the melanoma group, and it's really my pleasure to say on behalf of my colleagues, Dr. Devar, Dr. Kirkwood, all of our wonderful APPs, and research coordinators and research administrators and nurses and the whole enormous team, that it is really sincerely our privilege to take care of all of you. I just wanted to start off by saying that. And I'm going to be talking about a scientifically dense topic, but I hope I will make it understandable. And if not, please let me know and I'll be happy to answer questions. So what we all do here is research. We are trying to make treatments for melanoma better than they are. And I'll be talking about one broad avenue of research in oncolytic immunotherapy for the treatment of patients with melanoma. When I was in training many moons ago, we used to quote overall survival for a patient with metastatic melanoma in the order of months. We would talk about an average of about 6 months, and it was often less than that. And we have seen an incredible paradigm shift in the past decade plus, as new treatments have come into the clinic from the clinical trial space, including immunotherapy, which has accounted for the biggest shift here. And we now see patients who are living with cured melanoma. We think about half of patients with metastatic melanoma are cured of their disease, which is just incredible. And honestly, never thought I would see it in our lifetime, and it has just happened. And of course, what Dr. Kirkwood and Dr. Devar and I do is try to figure out, what about the 50% who don't see cure with their frontline therapy? 50% isn't good enough, right? How do we move the needle? How do we get more patients cured of their disease? And so this is where clinical trials come in. In between 1975 and 2011, there were approvals for a couple of drugs based on single-arm clinical trials. And from 2011 until now, we have seen 15 new approvals. Every immunotherapy has been approved first in melanoma and then gone on to other solid tumors. Every combination was approved first in melanoma and then went to other solid tumors. The first bispecific T-cell engager, melanoma. The first oncolytic virus, melanoma. The first cell therapy, melanoma. I think you can all see the trend and the point I'm trying to make, which is that melanoma oncology has pushed the envelope for all of solid tumor oncology, bar none. And that's something we're incredibly proud of and that we do with the support of all of our research partners. We also have the targeted therapies for patients with BRAF mutation positive melanoma, of which there are several combinations approved and which are really life-saving for patients when we use them. I won't get into the adjuvant space, but suffice it to say that a lot of what we have done in the metastatic space has been moved into the adjuvant, meaning post-op preventive phase, and has been shown to significantly reduce the risk of melanoma coming back for patients with resected stage 3 or 2 melanoma. So the current treatment paradigm, very briefly, is to start off with immunotherapy usually, regardless of BRAF mutation status. And there are different options that we can use but the name of the game in 2026 is really combination therapy for patients with metastatic disease, either with ipilimumab, nivolumab, or with relatlimab, nivolumab, or Opdualag. And these drugs work very well. And the rare patients with metastatic disease will still receive anti-PD-1 monotherapy, which is less commonly used right now. But I'll go back to where I started. What about the patients who don't respond to therapy? What about the patients who respond and then relapse? Our options there are really limited, and what we do then is largely dictated by what we've done first. So what you do second really is predicated by what we use for our frontline treatment. So for patients who received ipilimumab and nivolumab, what some of you may know is Yervoy Opdivo, these drugs work incredibly well. 50% will never need anything else, but the other 50 who do, if they do not have a BRAF mutation, have very limited options. And those include further immunotherapy, although Opdualag after Ipi/Nivo doesn't work as well as the reverse, or clinical trials, which is what we all do, or cell therapy, which is wonderful, but very, very aggressive and an appropriate option for a minority of patients, I would say. If patients did not receive ipilimumab, nivolumab in the frontline setting, they do have more options, but suffice it to say that options for patients who progress after they receive immunotherapy, especially if they don't have a BRAF mutation, are limited. And this brings me to oncolytic immunotherapy. So what is it? I just want to make sure we're all on the same page. This is a kind of cancer treatment that uses genetically engineered or genetically modified viruses, which are found in nature, in order to really do three things. One is to selectively infect the cancer cell and leave the normal non-cancerous cell alone. Two is to replicate inside the cancer cell. Three, and this is of course the whole point, to destroy the cancer cell. And in addition to directly killing cancer cells, the oncolytic immunotherapy or oncolytic virotherapy, you'll hear us use these terms interchangeably, also triggers a systemic or wide-ranging, not just within the tumor, but throughout the body, immune response to recognize and attack the remaining cancer cells. So does that concept make sense? I see some nodding. Okay. So there are viruses everywhere. What we have done is learned how to modify them to make them go after cancer cells only. That's the gist. Now, this idea of using infective agents to modulate the immune system is not a new one. And I love history. And so I look at everything through the lens of where did this come from? And Dr. Coley in the 1800s observed that a woman who had acute leukemia actually was cured when she developed influenza. The same observation was made in a woman with sarcoma. And so they didn't have the sophistication to say something about activation of the immune system resulted in eradication of the cancer, right? This is something we now take for granted. But the observation they made was that infection may cause regression. Now, 150 years later, we have the scientific sophistication to understand exactly how that is done. Now, the history of intratumoral therapies is a long one, starting from 1893 with William Coley's first published observation. 2015, we saw the first approval of an oncolytic virus in the United States, and this was with TVEC. This was the data that led to TVEC seeing regulatory approval in 2015. It is a herpes virus that is made to infect cancer cells only. And the long and the short of it is it works nicely if patients have very limited disease. We all have patients who had what we call in-transit disease or isolated tumors on the leg or on the arm, something that you could inject. And in that scenario, it does work. But patients don't die of local regional disease. Patients die of metastatic disease. And this is where oncolytic immunotherapy, in my view, has failed us. We, until very recently, were not able to get an immune response from oncolytic viruses outside of the tumor where we injected them. And we've really been trying to get better at this for a long time. This is a list off the top of my head. And I'm sure if I went on a deep dive, we would find much, much more. We have injected all kinds of drugs into melanoma and other cutaneous tumors, including oncolytic viruses, cytokines, immune modulators, et cetera, with the hope of getting a response, not just in the tumor, but outside. And this brings me to RP1, which is an oncolytic immunotherapy. It's based on a new isolate of the HSV virus, and it's been engineered to essentially express an immune stimulating protein, which will lead to activation of the immune system inside of the tumor, killing of the tumor cells. And what we have seen, and I'll show you some of this in the coming slides, is for the very first time that I'm aware of, consistently, death of tumor cells far away from where we have injected the drug. This was the IGNITE trial. This was a phase 2 trial. Phase 2 meaning we are looking for a signal of efficacy. Is there enough here to do the big kahuna, which is a phase 3 trial? And the phase 2 IGNITE trial had 140 patients and enrolled patients who had already progressed on PD-1-based immunotherapy, PD-1 being the backbone of what we use, what you might know as nivolumab or pembrolizumab, Opdivo or Keytruda. And all of these patients had progressed with their disease, and we found that patients who had been failed by PD-1 had about a 30% chance, if you look at an all-comer cohort, of having a nice response. And when I say nice response, I mean shrinkage of their tumor burden by at least 30%. And this is true of patients who had seen the strongest that we have, Ipi/Nivo. This is true of patients who had never benefited from immunotherapy. Their best response was progression. This is true of patients who had benefited and then stopped benefiting, what we call secondary resistance. To put it in context, the current benchmark for a drug to be of interest in the second-line space, second line meaning after the first thing we do treatment-wise, is a response rate of about 30%. Cell therapy like lifileucel, which we use all the time, is a great option, but because of how much patients go through with it, it's really not an option for every patient. As I mentioned, it's appropriate for a fraction of our patients. And with lifileucel, we see response rates of about 31%. So 33% with a lot less toxic regimen is of great interest to us as melanoma physicians. And this slide, so this is a waterfall plot. Anything that's going down, anything that's under the x-axis is good. These are tumors shrinking. And you can see that most of the tumors had shrunk. In the blue are tumors that we had injected. In the red are tumors that we had not injected. And so the point that this slide makes nicely is that we are seeing reductions in injected and non-injected tumors. This is a sea change in our world. This is not something that we have seen before. This is an example of a patient who was treated. You can see that she had received immunotherapy previously. Her disease had recurred and did not respond to immunotherapy. The melanoma tumor on her forehead was injected, and you can see regression at a distant site of hepatic or liver metastases. The confirmatory phase 3 IGNITE trial is ongoing. I have the privilege of leading that trial here. And we have really been leading the charge nationally with putting patients on. I know we have many patients on who are listening or here. And like for every single trial, we thank you very much for your participation. It's not taken for granted. And what we're trying to do with this study is to prove in a definitive way, and the only way you can do that is in a phase 3 trial, comparing to something else. And of course, there's no placebo, that would be unethical, but there's what we would use anyway, which is a different kind of immunotherapy in the comparator arm. The drug is under a review at the FDA as we speak. We think it will be approved in April of 2026 to be available to patients commercially, meaning outside the context of clinical trial. So more to come there. Hopefully we will get good news. This is a beloved patient of mine. Katie, you know exactly who this is just from the picture. This is a gentleman who had galloping disease behind his ear, what we call in-transit disease. He went on the study and the tumors regressed drastically. This big hunk of tumor essentially died and fell off. And when I examined him, I could still see all of this pigment. And I said, there's still all of this pigment, but I'm sure it's all dead. I'm sure he's had a complete response, but the picture is not telling the story. And this is where biopsies are really essential. So we got a couple of biopsies in the clinic, and we found that, in fact, all the tumor is dead. He has had a complete response. We saw him in clinic 2 weeks ago. He's doing great. The tumors are even more, or even less visible, I should say. There is another oncolytic virus, RP2. So there's RP1 that we talked about. There's RP2, which is really the same thing as RP1, but it also has a moiety that activates CTLA4. CTLA4 being what ipilimumab binds, one of the most primordial mechanisms that cancer cells use to overcome the immune system. And this allows us to inhibit that mechanism. And ocular melanoma is a type of melanoma that has been left behind largely until recently, because patients with ocular melanoma do not respond to immunotherapy anywhere near as well as our patients with skin melanoma. And so this is a trial that is focused on patients with ocular melanoma only. This is led by my colleague here, Dr. Devar. We have treated many patients on the study, which is still ongoing. And the RP2 virus is injected directly into the liver tumors, which is where 90% plus of patients with ocular melanoma will have recurrence. So more to come here. And this is the trial design, which I won't belabor. But we saw early data from the study showing us promising response rates higher than anything we have seen in ocular melanoma that I am aware of that has an immunotherapy backbone, with response rates of about 1 in 3, and these do appear to be durable. So the phase 2/3 trial is ongoing as we speak. This is available at our site, as I said, being led by Dr. Devar. And the control arm is what we would use anyway in this setting, which is ipilimumab and nivolumab. This is a very new virus this is a trial that I'm leading as part of our phase 1 group. And it is a novel Western reserve vaccinia virus. And the science is really elegant, but I won't get into this in the interest of time. What they have done is to modify the virus to give it therapeutic payloads, meaning once the virus gets into the tumor cell, the virus itself will start transcribing and making new proteins. And these proteins are twofold. One is an inhibitor of TGF-beta, which is not a good thing to have in the tumor. And another is interleukin-12, which is a good thing to have in the tumor. And so by the time the tumor is infected with this, the virus is making these proteins and releasing them into the so-called tumor microenvironment. So this trial has 4 arms. It's ongoing. We're leading enrollment here. And I'll show you some very, very early data just to show that we are seeing very nice responses so far, although, of course, it's early days, in our patients with advanced melanoma. This was a patient who had progressed on 5 prior lines of immunotherapy, including prior oncolytic immunotherapy, including prior doublet checkpoint blockade. And over time, we have seen a deepening in this patient's response with 61% reduction in his tumor burden. This is another patient that we had treated, and you can see here that the picture is essentially showing you that the stuff of the immune system that is in there after injection is very anti-tumor, whereas what was in the tumor at baseline was very pro-tumor, which is the opposite of what you want. So we're really in the process of doing all of this, and my lab is involved in some of this work. This is another patient of ours here, a patient that I have treated on this study. We actually just saw him yesterday. We've been treating, injecting lesions in the right mid-axillary line, 2 tumors. One of them went away. There's only 1 left. But the lovely thing that I was delighted to see is that his lung tumor is gone. I never touched the lung tumor, but this is yet another oncolytic virus that is showing us responses far away. How am I doing on time? I don't have a watch.
Fine.
I'm fine. Okay. So how do we bring this into the earlier stages? For any kind of drug, why wait until everything has stopped working? Why wait until the patient has metastatic disease? What if we can use it in earlier disease stages to keep the patients from ever needing anything more? And with this in mind, I developed this clinical trial, which is being run. This is a so-called investigator-initiated trial, which is being run here at the UPMC Hillman Cancer Center, whereby We give patients who have clinical stage 2B or 2C melanoma, meaning these are high-risk tumors with an unacceptably high risk of recurrence for many patients. And we inject the primary site of the tumor with RP1, which is the virus I was talking to you about, 3 times before they go to their standard surgery, which is a wide local excision and sentinel lymph node biopsy. We've enrolled 20 patients. My lab is starting to do all of the analysis. We have a handful of patients left to enroll. But one of the key questions we're asking is, how is the immune infiltrate in the tumor changing pre and post injection? And this is where I think it's going to be really exciting, do we see anything that is unexpected in the sentinel lymph node? Because the sentinel lymph node has now been draining a tumor site that got injected 3 times. So more to come from here. There is also another clinical trial that I had developed that we just got the letter from the FDA saying the study may proceed this week. So hopefully this will be opening quite soon. And this is for patients with bulky, meaning I can see it on the scan or I can feel it with my hands, melanoma, which is very different than the prior study I showed you. And here patients get RP2 being the drug I told you is being looked at in ocular melanoma, but here we're focusing on skin melanoma. And we inject the RP2 into the tumor. This here says 5, but we've just modified it to be 3 times into the tumor with Opdivo or nivolumab. Remember, the RP2 has that CTLA-4 binding moiety, so this, to my mind, is a triplet: CTLA-4, PD-1, and the RP2 virus. Patients then go for their standard of care surgery, which is to get rid of anything that can be seen, and then they continue their standard adjuvant therapy. The beauty of a neoadjuvant trial, neoadjuvant meaning preoperative, is that you can get a biopsy at baseline, and then you get a specimen from the OR. And the only way that we have made any headway in any cancer, but I think in particular melanoma, is by so-called translational science, which is where we study tumors, we study patient samples in the lab and understand what is happening. And this has informed every single study that you have seen me go through, bar none so far. So more to come on this, and we hope it will be open for enrollment. Our goal with all of this is to move every patient to the so-called tail of the curve. It's wonderful if you happen to be in the top part of the curve, you're alive and you're well, and you've had a response to Ipi/Nivo. But the fact that 50% are not responding or initially respond and then are failed by these drugs is unacceptable. And we are trying to do better for this patient population. And our goal here is to close this gap so that every patient is a durable responder. And with that, I would like to thank every patient. It blows my mind when we tell patients we need to do 3 biopsies for research. And they say, sure, that is really not taken for granted by any one of us. And all of the labs that work here, and of course, my colleagues. And I will be happy to try and take any questions.
Questions from the audience? Hand up or however you like.
We already have 2 online, so while people are thinking about the wonderful talk, Dr. Najjar, really inspiring. So we have one question from the Facebook land. Does immunotherapy work differently for different patient populations? Do certain people respond better while some others don't? And do you have some kind of a idea of which patients may be benefiting more from these interventions you were discussing?
The person asking this question has asked a multi-billion-dollar question. And the way I would put the question scientifically is there a predictive biomarker to immunotherapy? And the long and the short of it is not yet. And this is something we're working on very hard. So ECOG, which is one of our national cooperative groups, I have the pleasure of leading the immunotherapy committee. And we have really tasked ourselves with trying to develop or further develop and validate predictive biomarkers. We know that immunotherapy works better for cutaneous than it does for mucosal or acral, which is another type of cutaneous. But other than that, I would say there are a lot of studies that look interesting, but nothing that we would hang our hat on when deciding how to treat a patient. We don't know upfront who is going to benefit and who is not.
Absolutely. That's what all this research is all about. So great. Thank you. The other one from, again, online is how can patients get access to these oncolytic immunotherapies? Is it like only in our like Pittsburgh campus, or like do we offer it in our any other like Hillman satellite centers too?
So the trials are currently only offered here. Part of that is because the IGNITE trial, which is the phase 3 of the RP1 in cutaneous melanoma, requires visceral injections, which takes a very high-level interventional radiology expertise and a lot of coordination. For RP2, I don't think it's open at other sites, but I don't want to speak for Dr. Devar. Do you happen to know? Everyone I've treated here. For my own investigator-initiated trials of RP1 and RP2, those are only here because the tissues come straight to my lab. But I will say the big industry-sponsored trials, the IGNITE trial and the ocular melanoma trial, these are enrolling nationally. But in Pittsburgh, they're here. Okay. Thank you.
Thank you so much. Yeah. Well, as you all know, we have historically had our talks from the faculty, from the staff, from the advanced practice providers in our program. But one of the real pleasures we have is bringing in the next generation of investigators into our studies of melanoma. And that question that Param just mentioned about biomarkers, who is going to respond, who is going to get bad side effects, who will have unexpected outcomes from our treatments with immunotherapy, is a question that we've all puzzled about. And one of our medical students, Sabrina Bruno, has spent a year working on this, and will tell you today a little bit about how blood proteins may predict who will get side effects as well as who will benefit. Sabrina.
Thank you, Dr. Kirkwood, and hello, everyone. I am a third-year medical student here at the University of Pittsburgh. I've been working with Dr. Kirkwood for a few years, so I'm excited to be here today to tell you a little bit about what we've been working on. Like Dr. Kirkwood said, the study we'll be talking about today is using blood proteins to predict immune side effects in melanoma patients treated with immunotherapy. So to start, just a quick reminder on chemotherapy versus immunotherapy. Chemotherapy works by directly targeting cancer cells and any rapidly dividing cells, so hair cells, intestinal cells, to result in cell death of those cells. Immunotherapy works by using your own immune system, boosting it to fight the cancer. So today we'll be talking specifically about anti-PD-1 immunotherapy. So this is approved for stages 2B through 4 melanoma. And it goes by many names. So I put some of them here so you can recognize them if this is a treatment that you maybe have discussed with your oncologist or might be on yourself. So there's nivolumab, pembrolizumab, and there's also used in combination. So you might be on one of these combined with another. And anti-PD-1 works by targeting cells when they are tired. So the immune system fights for a long time, and after a while, it decides that it cannot continue to fight against the pathogens or the cancer. When this happens, it informs the rest of the immune system by putting an exhaustion marker on its cell surface. And one of these exhaustion markers is called PD-1. There's also TIM3, LAG3, both in this little graphic. So how these immunotherapies work are they bind this exhaustion marker, and that triggers the cell to keep fighting. So it's no longer exhausted, and so you overcome this exhaustion and all of your cells continue to fight for cancer. The challenge with this is increasing and boosting your immune system to fight the cancer also creates side effects. And the side effects that we see are a little bit similar to autoimmune disease, which makes sense since you're boosting the immune system, you get things similar to when the immune system's overactive. And we've coined these immune-related adverse events. In the study that I'll talk about today, 56% of our patients had an IRAE, or an immune-related adverse event. These can range from being pretty tolerable, a rash, you might have to use a cream. They might be treatment delaying, meaning you have to take a break from treatment, wait for things to calm down, maybe use a steroid. And some are unfortunately treatment ending, meaning you won't be able to complete your treatment because the side effects are so severe. So what we want to do is to predict who is going to get these side effects. Right now, it's largely unpredictable. There's some questions that your oncologist will ask you, like, do you have a history of autoimmune disease or certain organ dysfunction that might be able to help them predict a little bit if you're at higher risk. But a lot of people, it's very hard to say if they're going to have these side effects. Another thing is these side effects can affect every organ system in the body. So on this image here, you can see it can affect your liver, your lungs, your skin, almost everything. So the other question is, what will it affect for which people? So how can we monitor side effects if we don't know exactly what one this person might receive? So our goal is to both predict who might get these side effects and also predict which side effect they might get. So now talking about our study, who did we include? We looked at stage 3, so lymph node positive melanoma patients who received this anti-PD-1 therapy and who we had baseline blood samples for already in the biorepository. So this biorepository, you may have been asked in the past to donate blood generally for research, even if you're not on a trial, and your blood goes into this biorepository and let studies like this be possible. So thank you so much to everyone who has donated blood to that. And we also excluded people with known autoimmune disease since they are a category which we already know are at higher risk, and we wanted to look at a little bit more of the unknown category. So this yielded 43 patients for this study. And what did we measure? We had a large panel of 40 proteins. These proteins were largely inspired by rheumatology literature. So the doctors who already look at autoimmune disease, we looked at what they're looking at and said, well, maybe if they have markers that could predict autoimmune disease, maybe that would also work for IRAEs because there's some similarities there. Then we used statistics to be able to compare different groups. So we wanted to compare these protein levels in patients with IRAE and those without, and then specific IRAEs as well, which I'll show in a bit. And then we also looked at if these protein levels were at all associated with progression or with survival. So moving to our results, the first comparison we did was just overall IRAE versus no IRAE. And these, again, are baseline blood samples. So this is predicting before any treatment if there's any difference between these groups. And we found two proteins that showed an association here, and they happen to both be in the same class, Cyglec-7 and Cyglec-9, and they were both higher in those with IRAEs. Cyglecs are proteins that are involved in self-tolerance, meaning they help your body tell what is your own tissue versus what is a foreign invader, like a pathogen or a cancer. And so there's already some research going on with Cyglecs, so it's interesting to have this finding, and also helps us feel encouraged that maybe this is something that should be looked into even further. After this, we did comparisons for particular groups of IRAE. So the first group we looked at was dermatitis. So the comparison we did was dermatitis versus no dermatitis. Dermatitis affects a lot of patients in this study. It affected 30% of our patients. And these rashes can range from, again, very like tolerable, you just need to use a cream and that alleviates symptoms, to having to stop treatment for a while and letting it calm down. So it's a very broad class. It affects a lot of our patients. And we were able to identify two proteins that might be possible markers for having dermatitis. The next one we looked at was thyroiditis. This also affects a lot of our patients at about 15%. And for this, we were able to identify about 3 proteins. 2 were increased and 1 was decreased. So that's just the difference there. And then the next one is colitis. Colitis affected a smaller portion of our patients, only 3%, but these symptoms can be very difficult to deal with. So it's also one that we would really like to be able to predict. And we were able to identify 1 protein that could be a possible biomarker for this. And then the last group that we looked at is hepatitis. This is usually picked up on labs, elevated liver function. This is why your oncologist is often checking your liver function at all of your follow-ups. And this affected about 2% of our patients. And we were able to identify about 5 proteins that might be possible biomarkers. So for these proteins, we used a very hypothesis generating analysis where we were just trying to pick out what was significant. And all of these will have to be further evaluated on an individual scale and need much more research. But it's just promising that we did get a lot of different results for not only IRAE, but also these specific subtypes, which hasn't been looked into as much for these specific subtypes. The next thing we looked at, so we're no longer comparing two groups, now we're looking at survival analysis, is do any of these proteins, can they be used to predict who might progress or who might have longer or shorter survival on these treatments? So for progression, we were able to identify 3 potential biomarkers that are associated with progression, so they could help us predict who might have a progression and who might not. And then also for overall survival, it's looking at mortality, and we were able to identify 1 potential biomarker to help us with this. So that was a lot of different numbers that I threw at you. So just to sum up kind of what this means for you and what we identified here, we identified 2 markers for IRAE. We identified 1 to 5 markers for different categories of IRAE, 1 for overall survival, and 3 for progression-free survival. So overall, we're offering 17 candidate biomarkers for future research to identify, hopefully, eventually a blood test to be able to help us predict some of these things. So these tests are not available in clinics today. More research is needed, as I mentioned. But our goal here is that we're trying to move towards a personalized treatment plan. So when you come to your oncologist first to pick the treatment, they could do this blood test to help them select which immunotherapy to choose. And then also it would help a lot with monitoring. So if you knew that you were at increased risk for hepatitis, for example, maybe we would check the liver labs even more frequently than we already do. And if you're at increased risk for colitis, maybe you would be able to track at home bowel movements and relevant symptoms so that you can pick up on these side effects earlier and come to your oncologist sooner, knowing that you're at higher risk for them. So overall, this would just give us more information to be able to better pick your treatment and also monitor while you're on the treatment. So yes, that's everything I have today. Just want to say thank you again to all the patients who donate blood to the biorepository, letting studies like this happen. And also thank you to Dr. Knight. He is a resident, well now fellow who graduated, who came up with the idea for this study. And also thank you to Dr. Kirkwood for all this continued mentorship. Oh, questions?
Great. Well, biomarkers are really a horizon issue for us. And what Sabrina's related to you is really the basis for the blood draws that we ask for our patients, because they allow us to think that after the fact, we may understand what we don't always understand going into treatment. Questions?
Great, great. Anyone in the audience first? We already have one.
Great presentation. I just wondering, can you explain
More about the assay you've been used? No, what type of assay? Is it a standardized assay
So
or?
we use the Milliplex Immuno-Oncology Panel 2 for this, and that's the 40 proteins. I didn't include every single one just because it would probably be a lot to put on one slide, but it was a preformed panel. But we selected it by looking at kind of rheumatology data and trying to pick which pre-designed panel we
Some type
want.
of ELISA assay, basically?
Mhm.
Okay, good, thank you.
I think we had a question back there.
Ryan?
Thank you. Thank you. My name is Brian Miller, MSL from Bristol Myers Squibb. So it's an honor and pleasure to be here and see so many people alive and online and support such a fantastic event today. So kudos to the group. I guess my question is, very interesting with the biomarkers. Do you feel these markers are for IO specific, or would it come down to disease state specific, meaning that I saw like hepatitis being there, things like liver cancers, right? Are these biomarkers going to be more disease specific, or do you feel it's IO in general?
So it's hard to say since we only looked at anti-PD-1. So all of our results are kind of restricted to just anti-PD-1. But the reason we looked at different diseases is that is something that hasn't been studied much yet. There is a lot of people looking at biomarkers. We're not the first to do that, but there aren't many studies that are trying to predict a certain type of biomarker. So I did feel encouraged that we were able to identify specific markers for hepatitis, for dermatitis, and things like that. So I do think this is a more disease-specific study than others that I've seen. But yeah, we are definitely still restricted to it just being applicable to anti-PD-1 patients, and there's also much more research needed to validate.
Great. Wonderful talk, Sabrina. And we have a few questions from the audience that are kind of relevant, but Dr. Kirkwood, you might also want to weigh in. So the first one is, if immunotherapy caused pneumonitis, what options would be open to melanoma patients if the melanoma recurs after the first round of immunotherapy leading to pneumonitis, let's say?
So pneumonitis, happily, is an infrequent complication, but we monitor for this radiographically and by symptom tracking. And we don't really have any of the biomarkers that were studied here that were in any way correlated to pneumonitis. But it's been of interest that folks who get pneumonitis and dermatitis seem to have a response that may actually be associated with the benefit of the immunotherapy. So that's the silver lining on the black cloud. But I think that this is a thing for future studies in larger numbers of patients, where we will have some who develop the pneumonitis with whom we can actually ask that question directly.
Great, great. Another one that's been brought up is about the durability of different immunotherapy combos. I think, Sabrina, you kind of like showed like a few biomarkers that are associated with like progression-free survival and things of that line. But in general, how durable, like the question is, how durable is Opdivo response for long-term disease survival? And do you think that these markers may be helping us, again, like the question that was raised in the previous session, in terms of like triaging which patients might be benefiting more, and like having like a gauge of the durability of the immune response right off the bat before we even start the immunotherapy?
I think that's the ultimate goal of this study and studies like it, is to be able to predict right from the beginning, which is why we only looked at baseline blood samples. Was we wanted to really focus on, we want to be able to predict. So we're hoping that with more research, more validation of the biomarkers that we present here and other studies, that someday it will be something that is in practice.
Another caveat is that survival studies require huge numbers of patients followed for prolonged periods of time. This was a rather limited number of patients, so it wasn't really something that we could hope to have a readout on. So, yeah. But for the future, for the next study, yes. Excellent. Super. Well, we're on time, and thank you, Sabrina. So as you gathered from Dr. Najar's talk and from Sabrina's, resistance to immunotherapy is one of the big hurdles we face, that after response, a substantial fraction, half of our patients lose their response. And in that setting, the reversal of this resistance to immunotherapy has been a goal of many of our trials over the years. So the next talk will be given by Nosa Eiler-Humwa, who's a second-year fellow who's taken this challenge on, who's actually followed up on a very interesting talk that we had at one of the national meetings a year ago that introduced a new antagonist to the opioid receptors that seem to reverse immunotherapy resistance in mouse models. And what Nosa will talk to you today about is a trial which is actually very close to activating, which will test this opioid antagonist as a way to reverse PD-1, that is to say pembrolizumab Keytruda, or Opdivo nivolumab resistance, which are really the biggest challenges we face in the clinic. Nosa.
Hi, everyone. Good morning once again. And I want to thank Dr. Kirkwood for the opportunity to talk to you about a trial that we are about to open at the UPMC. And just like the previous speakers have all talked about, our biggest concern, it's about those patients with melanoma who seem not be doing very well or responding to the immunotherapy that we're giving. And our question is just kind of like, how can we make these treatments work better for these patients? And that's one of the reasons why we are looking at this clinical trial. And essentially, immunotherapy has really changed, the treatment paradigm in melanoma. Patients are living longer, they are doing better. And that's really something that is very exciting for us in the field. But unfortunately, not every patient do well. And as Dr. Najjar talked about 50% of patients will not do well, even with this standard immunotherapy. So patients will respond initially, and suddenly they will start doing very poorly on these medicines. And so today I'm actually going to be sharing an idea about how to potentially tackle this problem. I'm just going to quickly summarize how immunotherapy work. Immunotherapy, there are special type of medicines, and essentially when cancer cells form in the human body, the body tries initially to get rid of these cancers by using its own immune system. And it's the common type of cells in the immune system that fight these cancers, they are called the T cells. And what happens is that, after a while, these cancer cells become very smart, and then they put forth their brake system to kind of apply brakes on this immune system. And what happens is that the immune system stops working. So what immunotherapy does is to take off the brakes off the cancer cells so that the immune system, that is the T cells, can continue to do their function. But the challenge is that after a while, the cancer cells get even more smarter, and they begin to produce certain type of proteins that will prevent the immunotherapy from working. Essentially, we call that treatment or immunotherapy resistance. And usually what we do is that when we find ourselves in such scenario, a patient who was doing very well on immunotherapy and suddenly they are not responding, or ab initio, the patient is not even responding, one of the things we do is to add more immunotherapy medicines, right? But unfortunately, we know that doing that may even increase, the side effects of this medicine because they are not completely harmless. So instead of us asking if we could give stronger or more immunotherapy, we decided to ask, for these patients who were doing well or not doing well in immunotherapy, are there some things in the body that are blocking the immune system from attacking this melanoma? And is there a way we can potentially take off this block so that the treatment could work better? And that led us to the opioid system. And many of us are very familiar with opioids, oxycodone, morphine. We know them as pain medicines. But interestingly, the body forms or makes its own opioids, and these are called endorphins. These endorphins, together with the opioids that we take, they bind to a special type of protein in the body. One of them is called the mu opioid receptor. But what many people don't know is that the opioids, whether the ones we take in or the ones produced by the body, they have a way of affecting the immune system. And so what this essentially means is that it could potentially reduce the effectiveness of the immunotherapy that a patient is getting. And this is what we've learned from research. And this is largely from experiments conducted in animals. We found that, that these opioid proteins, right, they can reduce the number of immune cells that enter the tumor to fight the cancer. And it can also make the tumors to become invisible to the immune system. And that essentially means that, and this can potentially mean a patient who was doing quite well and suddenly, is not doing well again. And that's because of these opioids. And we've also learned from animal experiments that blocking this opioid protein could have potentially reversed or restored immune activity against the cancer. But this has not been tested in human melanoma cancers. And this is the reason why we're looking at this study. And the big idea is these opioid proteins that is produced by the body, and for those patients who are on opioids for pain, if we block these proteins, is it possible? It's possible that we could help the immune system, the immune cells, right, enter the tumors and then begin to function and fight against the cancer. And essentially, this is what this study is all about. So the clinical trial is actually looking at a new oral medication that has the potential to block these opioid proteins and then help the immunotherapy to work better for patients whose melanoma is no longer responding to this, to the current immunotherapy. And the opioid protein, the name is oxalopram, and it blocks the activity of the opioid protein, but outside of the brain. So it doesn't have a lot of side effects like sedation that will come with some of these opioids that work at the level of the brain. And it does not affect pain control. So a patient who is taking, for example, oxycodone for pain could essentially continue that because the oxalopram will not affect the pain. And it doesn't cause opioid withdrawal, and it has been found to be safe in early studies. And it's just a pill that is taken. It's not an infusion. It is not IV or anything subcutaneous. And in terms of who can participate in this trial, again, people who have melanoma that arise from the skin, which we call cutaneous melanoma, and those who have received immunotherapy previously, and they are no longer responding to this treatment. These are the people that we're looking at. Essentially, we're looking at enrolling about 30 patients for this trial. And the treatment, everybody's going to get the same treatment, and essentially it's going to be a combination of this pill with Opdivo, which is an immunotherapy. And what we're essentially looking for, one, is this combination safe, right? That's usually for studies like this, we want to be sure that, even though individually, oxalopram has been found to be safe, nivolumab has been found to be safe, but we just want to be extra cautious that combining these two medicines together will be safe for our patients. And then we want to find out, giving these patients this medication, this combination of drugs, will it cause the cancer to respond better to treatment? And will it cause the cancer to shrink or stop growing? And will it also cause more immune cells to enter into the tumor? And like I said before, essentially the immune cells are the ones that fight the cancer. The immunotherapy just help or boost the effect of the immune cells in fighting the cancer. We decided to take this different approach, because we don't want to, we're trying to look for, are there more effective but ways of improving immunotherapy, but not increasing the number of immunotherapy medicines that a patient takes? Because the more the number of immunotherapy medicines, like the previous speaker presented, we're likely going to have more immune-related side effects. And we're trying to reduce that. We're not just looking at killing the cancer, but we don't want to put the patient in a position where their quality of life is so much more compromised. And this is an oral medication, which kind of will improve in terms of compliance. You don't have to come to the hospital to take the medication. You could take it within the comfort of your home. The only time you will come to the hospital is when you need your Opdivo. And it looks at an entirely different pathway that may interfere with the cancer treatment. And what this could mean is that it could help patients whose cancer stopped responding to immunotherapy. And it will also offer a potentially more tolerable treatment alternative. We've talked about the other, treatment alternatives for some of these group of patients, injections, but this offers a more tolerable and even a more cost-effective approach to approaching, to taking care of this cancer. And it could also open new doors for treatment in other cancers because there's an increase in the use of immunotherapy in other cancers, not just melanoma. So if these were to work, they could actually be translated to other cancers. So the benefit will not just be with patients who have melanoma, but other patients who have other cancers. If this works, this could actually also be tested in other cancers. But it is important for me to emphasize here, first of all, this is a clinical trial. So what this means is that we're still learning more about this. And we don't know if it's going to work. We hope it does. And in the safety, throughout the entire period of the trial, safety, we're going to be carefully monitored, and participation is entirely voluntary. And a patient can actually, if someone signs in for the trial, the patient can actually withdraw anytime within a trial. So it's not compulsory, it's entirely voluntary. This really matters to us because we've talked about, 50% of patients respond to immunotherapy, but we are really We're very excited about that, but we're really very bothered about the other 50% who don't respond. We care deeply about improving outcomes in our patients. And we frequently will encounter, patients in our clinic who are no longer responding to treatment. And we need new ideas to take care of this. And this is one of those ideas that is firmly grounded in science. I really want to acknowledge all our patients here for the support you give to us in paying it forward by enrolling in many of these clinical trials. It is really not very convenient, and but you are paying it forward for the next generation of patients who may have to deal with this cancer. And for that, we're really, really grateful. And I'm also very grateful for the collaborators at the Melanoma Center, our research team, and Dr. Kirkwood, who has been an amazing mentor to me. And hopefully we'll be able to get to a point where we'll boost the response rate in patients who have melanoma more than the traditional 50% that we already have. And doing that at very much reduced toxicity, not just toxicity in terms of the symptoms, but also in terms of the cost. And I really want to thank you everyone for listening, and I'm open to questions.
Thank you, Nosa. Open to questions. And one thing that Nosa said is important to probably restate, which is that this agent, axilipran, may work in people who need opioids for control of pain. Thankfully, for most of our patients, that isn't the case. But in the setting of melanoma, ultraviolet light, when it hits your skin, triggers a process which releases endorphins, those opioids that are made inside the body, so that this may be a problem even if you're not taking opioids, where the axilipran may reverse the PD-1 resistance. So this is applicable to all of our patients, and hopefully this trial will go forward quickly.
This is for anybody that takes any kind of immunosuppressive drug, like somebody for arthritis?
So this is not directed at other steroid, hydroxychloroquine, other arthritis.
Or the Humira.
Yeah, this is specifically for patients with melanoma who have progressed on the PD-1, the Keytruda, the Opdivo, the PD-1 inhibitors that are used to treat the disease. We'd certainly think about other kinds of immunosuppressives and reversing those effects if it works here.
Great. We don't have any questions online, but I mean, just to double down, so if you're on an opioid, oxycodone, or any other, it won't affect the pain control or anything.
No.
So
No.
That's a very important consideration. Great.
Well, thank you very much, Nosa. So what you've heard about so far is really the treatment of advanced disease, the treatment to prevent relapse, what we call adjuvant therapy. Both of these are things that cost us hundreds of thousands of dollars, are toxic, and are, in a bigger sense for the society, unsustainable therapies. One of the things we've thought about, one of the things we've dreamt about for years is maybe preventing melanoma with interventions that will reverse the process at its inception. And the next talk will be given by Emma Kozic, who has joined a board already studying the process that leads to funny moles, what we call atypical or dysplastic nevi, that we actually first noticed in 1984, I have to admit, a long time ago, studying patients with melanoma in Australia, who a third of them had these funny moles, which we now know are associated with a higher risk of new melanoma and are what we call a non-obligate precursor, but a risk marker for melanoma. So the trial that Emma will talk about has taken us 6 years to get through the wickets. It actually activated last week nationally, and we hope to see it open and ready for accrual this week, like even Wednesday. So Emma, please.
Thank you, Dr. Kirkwood, for the introduction, and thank you all for being here today. We really appreciate it. I'm very appreciative to Dr. Kirkwood and everyone on the slide for allowing me to join in on this very exciting study. So like he mentioned, it just launched, and what we're looking for is whether sulforaphane or broccoli sprout extract actually could be used to prevent melanoma, specifically in patients who have already had a diagnosis of early stage melanoma and have multiple atypical or funny moles. So why do we care about the atypical moles? As Dr. Kirkwood mentioned, they're considered kind of an intermediate in between a benign mole and melanoma. So while they're not cancerous themselves, they have some features that could be concerning for eventual development of melanoma. And actually, patients who have atypical moles are at over 10 times risk of developing melanoma. And while it's unlikely that a single atypical mole on the skin will eventually progress to melanoma, it's thought that over 20% of melanomas come from an atypical mole. So we think that patients who have had a prior diagnosis of melanoma and also have multiple atypical moles are at higher risk and would be a good target population for prevention. And we've seen through similar trials that patients with melanoma diagnosis and multiple moles are very motivated to participate in studies like this. And they're already involved in routine follow-up as part of their cancer survivorship. So it would be easier for them to come in for these lab visits. And currently there isn't any agent on the market for prevention of melanoma. So why are we interested in broccoli sprout extract or sulforaphane? So it was seen that in broccoli sprouts, there's over 5 times concentration of sulforaphane than in mature broccoli that you could get through a regular diet. It was first an object of interest because of studies showing that in regions where people ate a lot of cruciferous vegetables, so broccoli, cauliflower, kale, that there was actually a lower risk of developing cancer. Since that was noticed, there were multiple clinical trials that proved that it could be a preventative agent. Specifically in prostate cancer, it was shown that patients who took sulforaphane daily had 50% longer time to progression of their disease. And also it was shown that in sulforaphane applied topically to the skin, that it decreased the negative effects of UV radiation, which we know is a primary driver of eventually developing melanoma. While the mechanism isn't fully understood right now for how sulforaphane works to decrease cancer risk, it's believed that it helps with antioxidant pathways, so preventing damage in your cells that would lead to the progression of cancer. So we first looked at this in a pilot study. So the phase 1 study was mainly to see, is sulforaphane safe for patients to take? And we found that it was. So we looked at 17 patients who had a prior diagnosis of melanoma on the skin, and then if they had more than 2 atypical moles, and they were given varied doses of sulforaphane daily for a month. The moles were photographed, a biopsy of 1 lesion was taken, and they also had blood samples drawn. And what we found in this study is that when given by mouth, sulforaphane was able to reach adequate concentrations for treatment in the skin. So we know that if we give it by mouth, that it could reach treatment effects. It was also safe for all patients throughout the month. There weren't any adverse effects to the patients for taking it, and they were all able to finish the treatment. And while it was only a month, we weren't able to see if there were changes in the moles themselves, but we did see in the blood that there were decreases in inflammatory markers that are linked to the progression of cancer, some of them listed on the slide here. And so what we'd like to do in the phase 2 trial that's launching soon is look at over a longer treatment period, so over a year, is there a greater impact on the total area of the moles and prevention of progression? So a very interesting part of the study is Vitel's Derma AI software. So this is a new tool that they use to take photographs of the skin, and it will compare over time changes in the moles in that area by aligning the photographs. So it can detect if there's an increase in area, if there's been new moles that appear, and if any of the moles disappear over time. And when we used it in the pilot study, we saw that it was over 90% accurate in aligning these images and comparing them. And also it could detect lesions as small as 2 millimeters. And this is as accurate as traditional techniques that have been used. So we're really excited to be partnering with them for the phase 2. So as I've touched on, what we're primarily looking at in the phase 2 trial will be taking a photo of the back of the patient and comparing changes in the total area of the moles over the year. And we'll be using the AI software to look at those changes and seeing if the sulforaphane has greater effect on these changes than placebo. So we'll also be looking at how many moles had significant changes in the area, what features specifically changed in the atypical moles, and if sulforaphane continues to be safe, which we expect it will over the course of a year. We'll also be looking at those inflammatory markers through blood draws. We'll be looking at if there's a decrease in inflammation in the atypical moles themselves and what features specifically change at each time. So who is eligible for this study? This is patients who have had a prior diagnosis of early stage melanoma and have undergone removal of the mole. They also have to have at least 3 atypical moles that will be diagnosed by a clinical exam. So there doesn't have to be any excision of those moles to be included. And they also must be over a year out from any immunotherapy, chemo, or radiation to be included. They'll be split up by age over and under 50 because we've seen that there's different characteristics of atypical moles by age, and they'll be randomized. So we will not know what treatment arm they've been assigned to, and neither will the patients, so that the results are objective. They'll either receive 3 tablets of the sulforaphane daily for the year, or they'll receive placebo 3 times daily for the year. They'll have a clinical skin exam every 3 months by coming into the office to look for any changes in the moles. They'll also have a photograph of the trunk for that AI software. That'll be at baseline, 3 months and 12 months. At those visits, they'll also get a biopsy of 1 atypical mole. They'll get a blood draw to look at the inflammatory markers. And then they'll follow up with us for a year after the study ends to make sure that they don't have any concerns and that there isn't any progression of disease. And then we'll be comparing the results over each time. And we're hoping to accrue 120 patients for this study. And as Dr. Kirkwood said, we're excited that it's going to hopefully be activating this week. So thank you again to everyone for being here. We really appreciate the support, and thank you to all the sponsors. I'm happy to take any questions.
Thank you, Emma. This is really the first prevention trial done for melanoma in the world. So this is something which we're happy to pilot again. As Jana mentioned in her first talk, melanoma has been the flagship for interventions with immunotherapy. And in this particular case, we are hoping to learn how to prevent the development and to follow these funny moles in a way which is rigorous with our local, and I should mention, Ellen Hughes is here from Vitel. If there's anybody with tough questions about the image registration, that was no small challenge, because in fact, to develop the co-registration program that they have developed took us years. And Vitel really was a wonderful partner in developing this with the standard pictures that we take in anybody who has more than a few of these moles that we want to track, because we can't remember what we saw a year ago when we see it today in the clinic if we don't have photographs. So photographs are part of what we're going to be doing for anybody with funny moles going forward, but it's part of what we need to learn what happens on placebo as well as on sulforaphane. So this is really a really exciting new study. And so questions?
Actually, on this very topic, we have a question from the audience. So if there is an AI software like an app store or somewhere that they can actually use to do monthly skin checks on their own, I'm not sure if it's only for like clinical trial use, or is it like a version that like patients themselves can utilize?
To do monthly skin checks. Yes.
Okay. Great.
Yeah, I can't answer that. I know that there aren't any approved approaches to photographic follow-up, although it's something that a bunch of folks have tried in the past to do smartphone camera pictures and follow them that way. But this done with a professional photographer using a landscape picture of just the back, we're going to use to track the pigmentation over time. If this works, then I think the floodgates will be down and we can think about how to bring it to larger numbers of patients in other settings as well.
Great. And the other question is sulforaphone available to the public as some kind of a topical oint or something in that line as well?
Yeah, so this has actually been an approach that a number of us in the field have been asked about. And if you have a funny mole, to put the sulforaphane on that mole might be an approach for that mole. The problem is, as Emma mentioned, any given funny mole that you have is very unlikely to become a melanoma. It's just a risk marker. And it's the one we don't see on the back, for instance, that is likely to become the melanoma down the road. But the individual moles that people have are not, in our opinion, the likely basis of new melanomas. It's really as a marker of the risk over the entire skin, which is why we need photographics for follow-up of the entire skin in the end.
And what we're doing here is a tablet, like an oral tablet, not an ointment or anything.
This is an oral tablet, as Emma mentioned. We did in 2015, 16, 17, a study of 3 different doses of broccoli sprout extract. And that showed that the low dose didn't really get into the skin. The middle dose got a little bit into the skin, and the high dose a little bit like Goldilocks, but basically the high dose got into the moles and seemed to have the ability to reverse these markers that we see potentially associated with progression of melanoma. So this is necessary to be a systemic, oral, or in other agents, potentially intravenous, but oral, the vastly simpler way to go. We were very happy that the company called Nutramax was willing to provide us this agent. It was going to cost us $500,000 to get this if we had to have it made for the trial. And they were already involved with doing sulforaphane trials in bronchogenic lung cancer. So they said, we'll do this for melanoma as well. Thank you, Nutramax.
Right. Anyone in the audience?
Questions? Param, any more online?
No.
Nope. Emma, thank you so much.
Thank you.
Well, this is great. We're a few minutes early, and so what we'll do is go to break now and try to resume at 10 o'clock on the nose so that we let everybody out for what's promising to be a gorgeous day out there. I can't really see, but it's the second day of spring, so we ought to let people out if we can. See you at 10. Thank you.
Okay. I got you. I was just gonna come hunt you down. I just did that.
It is the one, the final one. So that last one.
Right there.
That one. Yep.
So it's good.
Okay. Thank you. Sorry about that.
No, that's no biggie.
Figured the break would be a good
But
time.
that's perfect timing. That's.
Thank
Good
you.
luck. Thank you.
Advanced training session.
See that arrow?
Yes, sir. Oh,
That's the one.
is that hard?
I think you can handle it.
Okay.
I can highlight it pink.
Even I can figure that out. Thank you.
You're welcome.
Yeah, the minimum funded, right?
Hi, how are you?
I'm Ryan. I'm the one right after Dr. DeVar. Just here for you. Yeah. Thank you. Appreciate it.
Well, hoping that everyone had a good repast and is recharged for the second half of our talk. For the second half, or before we get started with that, I want to say one question came in just as we were breaking, which was how to join the study for prevention. And the answer is check with any of us on the faculty. It's a trial that would be called 26039 through the Hillman, but it'll be available through all the Hillman sites. And we're going to actually try to involve Roswell, Penn State, Cleveland Clinic, Ohio State, all of our regional collaborators in this. And any of them, or any site that is convenient to you, would be possible to enroll you on that trial. But it's called ECOG Akron 6232. It is otherwise known as Hillman 26039. So with nothing more ado, turn the baton to my colleague for the last dozen years, co-chair of the melanoma program, Dr. Zuro.
Very good, thank you, John. So we're going now to go toward the second part of the meeting. So I call it the program with John. I'm a dermatologist, so some of you may have seen me in consultation, but most part of my time is devoted to research. I would like to thank you very much to participate to all the new things we propose to the patient. We often ask you to give additional blood for study, to look at the impacts of the treatments, right, to understand why do you respond, why patients do not respond, and try to do better. Over the past years, we also start to ask a patient to give some stool sample, microbiome, right, because there is a growing evidence that the guts we have, the microbes we have in the gut, play a critical role in driving response or resistance to treatment. And based on that, we are designing a number of interventions, which can be, we did a fecal transplant. A number of companies are designing a specific consortia of microbes, that you can take. This is a possibility. And another way to influence the gut microbiome is, of course, diet, which is maybe the best way to do that. And that's what is leading to a number of diet interventions that you may have been proposed to join recently. So with this introduction, I will now, we're going to start this session and introduce Dr. Davars, our Associate Professor of Medicine. He's a medical and translational oncologist who's going to talk to us about dietary influence on immunotherapy.
Okay, thank you to Hassan for that kind of introduction. So I thought I'd talk to you guys a little bit about the role of the diet. And so why, right? So why do we think about the diet? Well, there are really sort of two reasons to focus on the diet. The first reason is, you can control it. You can't control how well any given treatment is going to work, but you can control what you eat, and you can control other things that you do to yourself, such as how much you exercise, how much you move. And one of the interesting things over the last sort of 10 years has been trying to realize the impact of all these other factors upon the likelihood of somebody responding or not responding to treatment. So this is the spectrum of all the treatments we have. We've spent a lot of time here talking a little bit about all the stuff at the bottom of that. And the reason why that's very important is because, about 15 years ago, we had all of these new drugs. So really, it's the modern era of drug development in this disease started about 15 years ago. And since then, we have made these dramatic changes. We've got these new drugs, checkpoint inhibitors, now cell therapy as well. And these drugs have resulted in dramatic changes in the outcomes for our patients. And how do we know that? Well, for the first time, right? So this is actually NCI data. The number of people who are dying from melanoma has actually reduced in the last 5 years. So up until 2018, the death rate, was always going up. But since 2018, we now have data showing that melanoma, and actually melanoma is the disease that has the greatest reduction in death rate. There are fewer people dying and over the last 15 years as a result of these drugs that we developed that I showed you from before. Unfortunately, not everybody benefits. That's actually one of our problems. And so we've been thinking about how do we get these drugs that have already reduced the death rates to actually impact the death rates even more? How do we reduce and dramatically increase the number of people benefiting from this disease, from the treatments that we have for this disease? And historically, trying to understand why these treatments work, I focused on three major underpinnings. Firstly, what the cancer looks like, right? So people go, they get a biopsy report. They oftentimes ask their cancer doctors, what are the tumor-associated features in my tumor that are present? Do I have the BRAF alteration? And we now have new and better ways to target BRAF. We also have ideas around what are the tumor microenvironment. You heard a little bit about opioid receptors. And part of the idea behind that is that opioid receptors are actually present in other cells in the tumor microenvironment. And sometimes opioid signaling can alter the presence of myeloid suppressor cells. Then we also look at host factors. What are factors unique to the host in our immune system that make it more likely or less likely to respond to the therapy? But what we are focusing on is this last part. And the reason we focused on the gut bugs is because the gut bugs represent, as in terms of firstly numbers, equivalent numbers of cells to the human body. So on the average person has got about 40 trillion organisms. Now that starts, these are numbers of such large scale that most people don't even realize how many these things are, because a trillion is not exactly a small quantity of something. A trillion's a lot, And so you have about 30 trillion cells in your body, and you have about 40 trillion bugs in your body. So the quantity of bugs really exceeds the quantity of cells, or is similar to the quantity of cells, but that's just how many bugs you have. It's a huge number. And that also means that the bugs are doing something. The quantity of non-human DNA in our body is similar or slightly exceeds the quantity of human DNA in our body. So we've been looking at the role of the host variables in affecting response to immunotherapy, just because if these bugs are so numerous, they sort of must be doing something. So what do we know about this? So the first thing is that when you think of everything that can go inside you, there's some pretty compelling data that antibiotics are sort of bad. Now, what do you mean by bad? So when you give mice antibiotics, mice that are getting immune therapy for the treatment of cancer, you can show that mice that get antibiotics appear to do worse compared to mice that don't get antibiotics. There's been sort of these large meta-analyses that you see over here that have looked at the outcomes of people who are getting immunotherapy with antibiotic use. And essentially, there's some pretty decent evidence that particularly recent, meaning within 1 month of starting immunotherapy, particularly broad spectrum. So not, 3 days of penicillin for a tooth infection or 5 days of augmentin for a sinus infection, but like weeks of antibiotics, 2 weeks, 3 weeks, 4 weeks worth of antibiotics, is associated with bad outcomes, meaning lower likelihood of response, lower likelihood of survival in immunotherapy-treated cancers, not just melanoma, but other cancers too. And as it turns out, this is also true for cell therapy. So CAR T therapy, CD19 CAR T therapy that we give to people with lymphomas and leukemias. So it appears to be that antibiotics appear to be less than ideal, particularly if they're broad spectrum, particularly if they're given for a long period of time. Two, in the principle of simple things that appear to be beneficial, turns out physical exercise is quite good, right? So in the context of checkpoint inhibitor therapy, there's been one study that has been shown that people that do more exercise compared to people that do less appear to do better. The benefit rate is about 10%. There's increased 1-year survival. And actually, there was a very large trial that was presented last year at our major annual meeting, which is known as ASCO. And in that study, basically, if you have colorectal cancer, after colorectal cancer, people are just usually watched. They get chemotherapy, and then they're watched. In the proportion of people who got chemotherapy and were being watched, Canadian investigators studied the effect of giving these people a structured exercise program. And as it turns out, if you got the structured exercise program compared to people who were just given advice to exercise, those people, colorectal cancer, they did about 10% better. So when you think about what this means, right? So these people didn't need any more chemo, right? So everybody was treated the same. The people who did better were just given exercise education and also got physical exercise and were coached through an exercise program, and they did 10% better. They didn't get more chemo, they just did better. A colleague of ours working with Dr. Zora and myself has actually shown that the effect of exercise may actually be because of the bug. So essentially, we don't quite know how exercise makes the immune system do better, but this investigator, her name is Dr. Maisel, showed that when you look at people who have better outcomes to immunotherapy, they appear to have this increased enzyme known as PFL. This enzyme essentially codes for a certain gut metabolite. And this gut metabolite known as serum formate appears to be increased in people who there's more formate in people who are doing better. And what she has shown is that when you put mice on a treadmill and you sort of turn the treadmill really quickly, it turns out mice don't have a choice. They have to do what you tell them to do. It'd be great if our kids did the same thing, but it turns out you have more influence over mice than you do over your kids. I've learned that as a parent. When the mice on the treadmill have basically more formate. So the idea, at least preclinically, is that this intervention of exercise may be because of formate, but it might be that formate is just one axis and exercise ultimately may do more than just formate, increase the levels of formate in your gut. The third thing you can do is actually eat more fiber. So these guys from MD Anderson, they looked at people who are getting more fiber, and that when they looked at people who are getting more fiber, they showed that people who ate more fiber, particularly more than 20 grams a day, they'd appear to do better. On the converse aspect, people who ate more fiber but also took more probiotics, they did worse. So it appears that fiber is good, but unrestricted use of probiotics is not only bad, it actually blunts the beneficial effect of fiber. And fiber appears to be good in multiple cancers. So this is actually data that's from the Memorial Group looking at fiber in a particular dietary intervention, looking at a high fiber plant-based diet. And so they gave people meals for 12 weeks and they coached them for a total of 6 months. And this is in people who had a high BMI, but myeloma precursor states. And basically, when you give these people a high fiber plant-based diet, you improve their BMI, you improve their quality of life, you improve the metabolic and microbiome outcomes, but more importantly, in the context of plasma cell disorders, you improve the immunological outcomes of these patients. So fiber appears to be good for multiple reasons. And then I think you'll hear from one of our very talented students about the effect of potentially fermented foods. The last thing I talk about is diet, a Mediterranean diet. Mediterranean diet also appears to be improving immunotherapy outcomes. This is a cohort study of 91 people from the UK and Netherlands, and essentially a high adherence to a Mediterranean diet was associated with a dramatic increase in the probability of responding to immune therapy. And what we've done over here is, we've known that fiber is good. We've known that fermented foods are good. We've known that antibiotics may appear to be bad. But one of the things that we observed around here was that there's a significantly large quantity of people consuming these artificial sweeteners known as sucralose, aspartame, saccharin, and so on and so forth. People have known that sucralose might not necessarily be the best thing for you. In mice experiments, people have shown that high intake of sucralose directly affects the immune responses in mice now without actually signaling via the sweet receptor. Admittedly, this was done in the context of non-cancer models. So when you look at this in the context of humans, this is data from the Elinav and Segal groups at the Weizmann Institute. It's really very dramatic that an intake of stevia or sucralose, just at the level of about 6 sachets a day, has dramatic effects, particularly sucralose, more so than stevia or aspartame or even saccharin, upon glycemic control and probably via the gut microbiome. So what we looked at in cancer patients, again, and this was work done here by asking people, some of whom are in the audience, how much sucralose you're taking, and then we take this quantity of sucralose, we study it, we look at some math models, and we convert this to outcomes. And what we're able to show is that if you take a quantity of sucralose that exceeds about 0.616 milligrams per kilogram per day, or about 10 to 11 Splenda packets, right, for a 70 kilogram person, those people do worse in immunotherapy-treated melanoma, immunotherapy-treated melanoma in the preoperative setting, and immunotherapy-treated lung cancer. It's not just melanoma. It's not just advanced cancer. It's also early-stage cancer. And it's not just one cancer. It's multiple cancers. So it appears to reduce the likelihood of people responding to cancers across the board by a factor of 2. And the way I think about that is a hazard ratio of 2 is actually quite high, right? We spend about $300,000 per patient for combination immunotherapy. We spend about $150,000 per patient for single-agent immunotherapy. And combination immunotherapy is about 15% better as a hazard of about 1.8 compared to single-agent immunotherapy, which means it's about 40% better than single-agent immunotherapy. So you could be on combination immunotherapy and be taking a large quantity of sucralose, and you're essentially negating the effect of that second drug that you just got. So that's how dramatic the effect is. The effect size is so high that it can blunt the effect of a drug. And so that's part of the reason why we think that these things that people are consuming have such a dramatic effect in people. There's a way in which sucralose appears to do this. When you look at in a mice model, it appears to be doing this by essentially directly altering the gut microbiome, resulting in impaired T cell function. Basically, when mice are given large quantities of sucralose, their tumors grow more quickly because the T cells work less well. So finally, all of this is bad, but what can you do about it? So one of the simple things you can do is you can try eating more fiber. So the guys at MD Anderson gave people more fiber. Now, they didn't give people, the recommended daily intake of fiber is 20 grams per day. That's what the US dietary studies recommend, 20 grams a day of fiber. If you can do 30, that's great. These guys gave people 50 grams of fiber. 50 is a lot, okay? 50 is a lot because, if you think of what 50 grams of fiber is like, right? So this is an example of what that diet sort of looks like. So you can look at the high fiber diet, which is on the sort of the right side of the screen, and the low fiber diet, which is on the left side of the screen. So your breakfast is a breakfast sandwich. But the high fiber diet is also a breakfast sandwich, but I'm pretty sure that the turkey sausage doesn't taste like turkey, right? It probably tastes something akin to grass. I have no idea what a black bean brownie tastes like, but I'm pretty sure it doesn't taste like a brownie. But the point is, there are ways to get there. That's the kind of the point. And the other thing is, it's very hard to go to a high fiber diet quickly. You have to ramp up slowly. Because if you go from taking about, what the average American is doing, which is about 15 grams of fiber, to about 15 a day, you might be very sick. And the reason is the fiber causes a lot of gas. It causes a lot of bloating. So not only will you feel a little uncomfortable, you'd be unpleasant to sit next to. So the reason is that you have to sort of do this in a stepwise fashion. So that's why they ramped up slowly. They went from 20 to 30 to 40 to 50 over a span of about a week. And what they showed was that, the baseline characteristics are not particularly difficult. There was some GI discomfort in these people, as you would expect. There was no change in the body weight composition between these high fiber and low fiber groups, but there was increased responses in the patients with high fiber. It wasn't particularly significant, meaning it didn't meet what we consider important, which is the statistical significance. But again, going back to the idea of how much benefit you can get without adding a drug. In the neoadjuvant cohort, just by giving high fiber, these people did dramatically better than people who just got the standard drugs alone. So again, this is something, again, people can control. You can't control whether or not you get another drug, but you certainly can control how much fiber you eat. So another thing that has got significance in humans. So the conclusions, I think, it's definitely feasible. It's well tolerated. It's not unsafe, and it certainly appears to work. But it is challenging, and it's not things that easy to do. One thing that we're going to be doing here is we're going to be studying the effect of exercise. So in a trial that we are working on right now, we're going to be asking people who are getting immunotherapy in the preventative setting, so these are people potentially in the audience a year from now, whether or not you'd be okay doing 6 months worth of exercise on top of standard health education. So it'd be one of those randomized trials where people have their cancer cut out, and then they're going to start immunotherapy with, say, Melissa or my PA or Katie in Dr. Kirkwood, Dr. Najjar's clinic. And then we're asking people, hey, do you mind getting yelled at by a trainer for 6 months? Okay, so it's 3 times a week for 6 months. And in addition to all the stuff that you're doing anyway, which is coming in here and getting your scans and stuff like that. And so that's something that we are about to launch in the next couple of months. So in conclusions, I think it's easy to tell people what to avoid, but it's not easy to do this, because this stuff is everywhere. If you like, my neighbor, for example, invites us over to watch the game. He's an Ohio State fan, so he's pretty upset right now. But he said, the standard drink that he used to drink a lot of beer, now he gives people High Noon. And I didn't realize this, but if you look at High Noon, it's got sucralose in it. If you look at diet soda obviously has sucralose or some kind of artificial sweetener in it. Turns out the stuff that we give kids, these protein bars or these Nutri-Grain bars, they have sucralose in it. So it's hard to avoid. It's simple to think that you can avoid it, but it's hard. Antibiotics, I think in large quantities appear to be bad. So I think the simple quantities of antibiotics are probably fine, but weeks worth of antibiotics might not be a good idea. But rather than saying that you should not do this, which is sometimes hard to do, think of what you can do. Again, things that you can control. So I think eating fiber is pretty self-explanatory. I think taking more fiber is probably a good idea. Ideally soluble, ideally more than 20 grams per day. If you go to 50, that's great, but again, that can be difficult. Fermented foods, you'll hear from Ryan later how much more this might be helpful. A Mediterranean diet that is high in poly or monounsaturated fats and is low on saturated fats, red meat, mostly plant-based, mostly fish might be beneficial. And finally, physical exercise, might be beneficial. Ideally, about 180 minutes a week, 3 times 50 is what we tell people. So if you can move for 50 minutes, that'd be great. But again, it's not easy to do. And it's not something you can do all at once every day. But if you start making steps in this direction, just think of the survival curves and how much money we spend to get from 1 drug to 2 drugs, and how very easily some of these deleterious effects can negate the effect of the beneficial drugs that we give people. So the idea is this is something that people can control. This is something that's within most people's power to be able to do. And it's not easy, but that's kind of what we're here for. There's a big team here. There's a big supportive oncology community here that is very interested in helping people sort of try to implement some of these interventions. So with that, thank you for your time. And these are my funding sources, and I'm happy to take any questions.
Already have questions coming from the audience online, but before that, I think we have a
The other day I came across an ingredient, allulose, allulose. What's the story on it?
So allulose, right? That was a question, right? So allulose is a non-absorbable starch. It's very similar to the word cellulose, So it's a non-absorbable starch that's present in some foods. It's actually used as a bulking agent. So I guess the question that people sometimes ask me is, how did we get to having all of these things in our food to begin with, right? Like, how did this even happen, right? And so without going down a long, meandering track that is going to make me sound like a TV host, what I'll tell you is that the United States started changing its agrarian policy in the 1960s and 70s because we became essentially we became not just self-sufficient, but after the Second World War, we turned vast farmlands over to make the making of soybeans and corn. So we had a lot of the stuff. We were making it. People came back from the war and they got, orange juice in the war because we were growing oranges in Florida. But we had all this grain and we had no idea what to do with it. So we had to, use it up. And so what we did was we started creating foods with it. There was no Doritos in the 1940s, right? You couldn't buy, there was no Chuck E. Cheese in the 1940s. All of these foods, Doritos, these high ultra-processed foods that contain allulose and thickeners and these things are inventions of the last 30 to 40 years. So grandma didn't cook with this. We did. And we did it because of changing industrial policy in this country that, that we can't really go down and try to explain. But these are new ingredients that were added to food to, one, use up the stuff that we already were making, but two, to increase shelf stability. Because again, 80 years ago, there was refrigeration. That's a technology that's been around for about 100 years or so. But you didn't need to make something in a certain place and keep it on a shelf so that 6 months later, you could buy it at Costco. But we're doing that now. And those things that you put in food completely unintentionally have this unexpected effect that most people never really thought about, So allulose and ingredients like that were added to foods to essentially act as stabilizers, leaveners, thickeners, stabilizers, to increase the shelf stability of foods and make sure that they maintain density, crispness, all the things that we kind of like. Like when you watch the Doritos ad, one big part of the ad itself is the crunch that you get, right? And all of that increased the palatability of foods. So it makes us want to eat it more. But nobody expected, fairness to the people that made it, nobody expected that these would be bad for you, but because it wasn't tested. And much like sucralose, the average daily limit of sucralose was 5 milligrams per kilogram per day. The average daily limit that appears to be harmful is about 5% of that. And again, it's because when people tested this in mice, they tested it in mice to try to see when the mice would sort of keel over and die and used a sort of fraction of that dose. But as it turns out, it's only a fraction of the dose that is needed to start altering the way in which you start processing and metabolizing these products, and for that product to start altering your own immune kinetics. So it's an unintended consequences of the stuff that we eat.
Oh, great presentation overview. Dare I say, food for thought, definite. I know you mentioned antibiotics, so I know there's some recent data. I wanted your perspective, especially for audience listening. Antibiotics is one thing. We've heard about things like Tylenol, ibuprofen, NSAID class, even PPIs like Protonix, if you're not familiar with the PPIs. Kind of your thought on some other common medications, even over the counter to avoid.
Yeah, so I think there's some pretty good data. So I guess the first issue to realize is that a lot of the concomitant medication use is, again, partly, unfortunately, not controlled, right? So if you think about, I think of a drug like Prilosec, right? Prilosec used to be an actual drug that you had to go and see the doctor to get. Now there's an ad for Prilosec that's, again, the ad is very telling, right? It's a big guy driving a lawnmower, right? A riding mower. And the whole idea is that if you're eating barbecue, you need Prilosec because the barbecue causes reflux. And the drug becomes so easy to get because it's over the counter at any pharmacy, right? But previously its use was controlled because you had to go to the doctor to get it. So people have shown that, including us, we've shown that PPI use appears to be negative. But forget immunotherapy. PPI use has been shown to be negative from everything from older patients, particularly women, and osteoporosis. There's a very strong link between PPI and increased risk of osteoporosis. So certainly it appears to impair outcomes to immunotherapy, but it also appears to increase your risk of osteoporosis, appears to impact vaccination efficacy. So I would avoid PPIs, not because I think it's bad, but because it appears to do more harm than good. Now, do I think that somebody who's having really bad reflux should be on a PPI? Probably. But I think where it becomes dangerous is when there's unrestricted use. So again, it goes back to the idea, please check with your doctor. But to Brian's point, they are, again, the idea of unexpected consequences of good drugs, right? There are certain drugs that appear to have unintended consequences when they're used beyond the period or the stated use. Antibiotics, certain classes of nonsteroidals and anti-inflammatories, and proton pump inhibitors appear to be among the broad class of drugs that when used beyond a certain, their intended use, right, appear to be less than beneficial and potentially even harmful. But again, in order to answer some of these questions in a granular fashion, you really need a lot of exposure outcome data, meaning you need to know how many people did poorly versus how many people did well and how long they got the drug for. But very importantly, what were some of the factors that mitigated or necessitated their use? Because sometimes it's the other factors. Like there's a strong role, for example, between pain medication exposure and bad outcomes to cancer immunotherapy. And that appears to be obvious. But if you don't control for the fact that many of the people with high amounts of pain who are on, therefore, pain medications have bad pain because of cancer in the bones. And as it turns out, if you have cancer in the bone, that is an independent risk factor for a bad outcome. So if you don't control for bone cancer involvement, meaning cancer involving the skeletal system, maybe the outcome is not that bad. And maybe people really should be on pain medication so that they get better and they go on the cancer treatment, because the alternative would be much worse. So I think the answer to Brian's question is a complicated one. The short answer is check with your doctor.
Great. And we have a good number of questions online that I'm trying to integrate into a few. So we have questions about sorbitol and gummy vitamins. We have monk fruits. And also like different like sugar alternatives that are available over the counter.
Okay.
What is your overall gestalt for like different
All right.
options?
So the first and the most important thing is there's a very, very exciting talk about the role of fermented foods that I do not want to get in the way of. So everybody, if they haven't listened, has to listen to Ryan. So tune in. So I don't want to get in the way of that. I would say that for those things like sorbitol, gummy vitamins, and all of those things, the best thing to do, again, is to check with your doctor. In order for me to explain each of these things in depth, it's going to take a lot of time. What I would say is that as a qualifier as a whole, artificial sweeteners appear to be as a broad class bad. And again, that's another very fascinating intervention. People invented sucralose in the 1970s when they were searching for an alternative to, does anybody know? I don't know. It was invented actually at a chemical plant in the UK when they were looking for an alternate to a non-stick surface. Okay, so there were a whole bunch of guys creating a whole bunch of chemicals and they were pouring it on dishes, and they were looking to see what would cause non-stick, because the idea was we needed a competitor to Teflon. And as it turns out, one guy created something, and then he happened to lick it, and he was like, oh, this is sweet. And then the guys in charge of the chemical plant were like, oh, you know what we can do with this? We can put it in kids' sugar cereal. And so that happened. So the point is, again, check with your doctor. All right.
Okay, thank you, Divakar. So we're going to switch to the next talk, but as an introduction, I would like to say two things. The first thing is to come back to what Yana told today, starting with that how much progress we did over the past 15 years, right? Stage 4 melanoma was really bad, right? So you had very little chance to make it. Now we are in a space where half of the people would live longer. So, and this is mostly because of the targeted therapy and the new immunotherapy, anti-PD-1, CTLA-4. I think we have been very lucky to have such progress. And now we are struggling to know what's going to be the next step. So we really were a lot of enthusiasm in the field. We thought that the next drug, the next antibody would bring us well above 50%, and this is not happening. Unfortunately, you can see, if you follow the literature or the news, you can see that many very promising approaches are failing one after the other, which really said that the field is getting complex, that it's unlikely, I think, that we're going to find the miracle drug who is going to help us to cure every patient. That tells us that we need to do more research to know better about the patient, what are the reasons why they respond, why they do not respond, and to try to identify a subset of patients and do some targeted intervention, right? So there may most likely have many options that may fit a specific group of patients and not the other. That's, I think, underline the need of the research we're doing here, right? When we ask you to give blood or give stool, it's also to allow us to understand per patient what are the mechanisms, why you do not respond, and hopefully to be able to tailor some treatment. And I think that's what's happening with the microbiome. We don't say that the microbiome or microbiome intervention will be beneficial to all patients, but I think a significant number of patients are going to benefit from it, right? And so to make a junction with what Dr. Davar, so our work and the stool that we have collected from you allow us to do some really in-depth study of the microbiome, try to correlate gut microbiome composition, the bugs that would be beneficial or deleterious to your response. And one striking observation that we found in this patient is that chronic inflammation promoted by the gut microbiome would be bad, right? So in general, gut microbiome composition that induced too much inflammation would be bad. This group of patients would not respond well to immune checkpoint blockade. So this has led us as a consequences to see how can we decrease chronic inflammation. And that's how we end up trying some diet intervention. And there are some data suggesting that among diet intervention, taking a lot of fermented food will be an approach to do that, right? So decrease inflammation, so possibly increase the likelihood of response. And that's the topic of the next talk by Ryan Camacho, who is a talented medical student.
Let me just set a timer so I don't go too long. All right. Hi, everyone. Thank you, Dr. Zaror, and thanks everyone for being here. Like everyone in the room and also kind of in the chat, after learning about the microbiome, like Dr. Dwyer talked about, you just kind of have more and more questions and kind of it can get complex really quickly. So one of my goals with what I'll talk about today is to just help patients build a framework or like foundation of how to think about the microbiome, and hopefully moving forward, as you guys hear more research, more kind of symposiums, you can build on that and kind of get a little bit of better understanding. Then I'll follow that up with, like Dr. Zaror talked about, why fermented food is interesting and how that fits into the whole concept of the microbiome. So this is an overview, essentially what I just said. So me, Sabrina, all the other medical students here are kind of lucky to be growing or kind of learning medicine in a time period where immunotherapy has like improved dramatically the outcomes in melanoma. And one of the key things that they're highlighting to us now is really why some patients are having toxicities, others are having great responses, others are having like somewhere in between. And microbiome has really been the kind of key connection with all that. What is the microbiome? It's essentially a fancy way of saying the bacteria that live on or with us or even inside of us. So everyone in this room has bacteria in their nose, in their mouth, also in our gut. That type of bacteria influences how our immune system acts. And essentially everything can influence it, from antibiotics like we talked about, dietary fiber, really just where you live, all environmental stuff. So this is exciting because we know melanoma, all immunotherapy outcomes really are linked with this microbiome, and some patients have worse microbiome. So when patients ask, what can I do to help my immunotherapy treatment? Diet is really like the go-to answer. That's kind of what makes this really exciting. So this is kind of helping to build that framework. So when they teach us about the microbiome, they really highlight how this is like a living, changing, breathing ecosystem. This nice image in the top left is essentially an empty garden. This is your kind of gut microbiome at birth, and it's empty. So just living throughout your whole life, you're going to have increased exposure to bacteria. So even if your type of birth method changes the microbiome, how early kids go into things like daycare, pre-K changes the microbiome. So that's kind of how it starts to develop. And with the microbiome and this whole analogy, I want you to think of bacteria as essentially like plants. So yeah, everyday exposure, you add some more bacteria. As we grow, think of someone had the same diet last 10, 15 years, kind of reach like a mature microbiome where it's a little bit more resilient. So that means if something impacts it, it could be a little bit harder to change drastically. And it's also a spectrum. So some patients have like healthy forest, probably causes no issues in like someone my age, or anyone's age. But there's also like a gold microbiome. So think of it as like a very healthy and thriving ecosystem, like a rainforest. So rainforests have, I don't know, hundreds or not thousands of different plants, animals, and they're all kind of living symbiotically. Even though they're producing stuff, there's like a healthy balance. So one of the things that with this analogy, I want to walk through is what happens when certain things interact with their microbiome. So one of the main ones is antibiotics. Antibiotics, unfortunately, is kind of like, this is, if you have like long-term, very broad spectrum antibiotic exposure, kind of like a wildfire, it wipes out the plants in your microbiome, and that can kind of have different paths. So some patients after antibiotics could have some like dysbiosis or like overgrowth, it's like C. diff, for example, but others can just kind of go back to the starting point and work their way up to something healthy. So knowing that, I'll kind of start building on that framework and explaining how different diet components start shaping that. So the first one, like Dr. Devar talked about, is fiber. Fiber is essentially something that when we eat, our body can't break it down. So it travels to our colon. Bacteria eat it, ferment it, make substrates from it. So it's essentially like fertilizer for bacteria. And then probiotics, another big thing that patients ask about. These are essentially like if you select certain seed packets at the store, put them in your garden in the microbiome analogy. So what we're interested in is fermented foods. This is a picture of kombucha. So this is called SCOBY. It essentially has like dozens of different bacteria, fungi, all kind of living symbiotically already. So you can think of this almost as like a mini ecosystem, which is interesting. So the reason this can get complex is because you use fertilizer, seeds, or like introduce mini ecosystems in different like environments, there's different effects. So fertilizer right after a wildfire where there's not a lot of plants really isn't a lot of things to feed. In like this intermediate phase where there's room for microbiome to grow, that could be beneficial. And then in this like phase where someone already has a healthy microbiome, if they start using only one specific type of fertilizer, you can start only feeding certain plants and kind of ignoring others. Same thing with probiotics. What's interesting is there are some studies that show it's beneficial in some patients, other patients not so beneficial. And then kind of the explanation, or at least the way I kind of build or think of it, is in certain scenarios, like this early one, adding seeds probably helps increase diversity, helps the patient get back to baseline. But if you're like in a healthy rainforest and you start throwing like, I don't know, tomato seeds everywhere on it daily, that could actually kind of hurt the kind of balance that has been gathered over time. So I'll just talk a little bit more about the fiber and then fermented foods with the next component. So Dr. Devar already talked about the kind of higher fiber, and this is something that we were all really interested in. But one thing I do want to caveat, just because in patients, when I talk in clinic, when I talk to patients about fiber, sometimes they'll ask, can I just like start like almost like chugging Metamucil or like different fiber things? That is not necessarily the best thing. What research has also shown is that there's different types of fiber. I think we like different fertilizers. So they act differently based on what plants are there. This was just a study that showed that they gave the same kind of fiber intervention to patients, and there were two different outcomes. And it was because of their differing kind of microbiomes at the start, A or B. So it's not as simple as increasing fiber by all means is going to help you no matter what. It really depends on the context. So in the context of what we talked about with the MD Anderson study, I want to highlight how they were increasing fiber in diets that were already very healthy and kind of natural, so whole food. So fermented foods is kind of what our group's really interested in. Like we talked about, it's almost like a mini ecosystem. And the big study that really made a lot of us interested in it was out of Stanford. They had patients for 10 weeks, so in California, increase their fermented food intake. And they saw that with higher fermented food intake, patients had increased gut microbiome diversity. And this kind of led to a whole bunch of different chronic inflammatory markers being decreased. So this is really interesting and kind of the context of cancer, because this is something that could both potentially help increase the gut microbiome diversity, which some studies have shown have been helpful already. And also, like Dr. Zaror talked about, chronic inflammation is something that is a risk factor for both cancer and also progressing on it. So that leads us to what we're currently studying at here at UPMC. The main thing that we were doing is really, I'll start it with, we have this microbiome repository of patients that provided us stool samples, and that lets us look at the microbiome. This is with Dr. Devar, Dr. Zaror, and everyone else. So when Kako, which is an oncology fellow that used to be here, Dr. Zaror and the rest of the team first saw the Stanford study talking about how fermented foods was beneficial, the question in their mind was, can we retrospectively see if patients that had higher fermented foods had different immunotherapy intakes? So we essentially called patients. Want to first of all take a moment to thank all the patients in this room that I likely have tried to call once or twice just to make you guys fill out some of these surveys, ask about your fermented food intakes. Without you guys, we wouldn't be able to kind of get some of these findings and research, but we call patients, ask them about the different fermented foods that they're eating, like fermented dairy, fermented vegetables, all different types of things. And then we kind of built up a huge database and we try to correlate it, see how if those patients did better or worse. So what we saw is after contacting a couple, 200 patients, 270 patients roughly, but of those about 200 melanoma, the average fermented food intake overall, so this includes everything, including like things that were fermented but no longer have like live bacteria, was about 4 servings per day. Interestingly, the only things that had kind of an average that was greater than one a day was dairy and coffee, which makes sense. And by dairy, this specifically is referring to fermented like dairy liquids, so yogurt, kefir, and then fermented dairy products. So that's like cheeses like cottage cheese, brie cheese, feta cheese. So what happens when we look at the patients that are above this threshold of 1 serving per day versus the ones that are below? What we found is that the patients that had increased servings of fermented food, specifically what I'm talking about here is dairy, they tended to have better outcomes in resected melanoma, so better EFS, which is just how long it took for certain events like recurrence or death to happen. And then we also saw, this is with the caveat that, like I believe Dr. Kirkwood talked about this before, with this kind of survival and outcomes data, it takes years to get a full picture. But based on the early data that we have, there seems to be a clear separation of patients that had greater than 1 serving per day of fermented foods and those that had less than 1 serving per day of fermented foods. So that's another signal that is encouraging in terms of, it seems like fermented foods, patients that have higher intake are tending to do better. But because it's retrospective, we can't kind of just recommend it to everyone right away. We kind of want to start testing if it's actually something that works in real life. So that leads us to kind of the conclusion, which is some of the ongoing clinical trials that Dr. Zaror and I'm helping with here at Hillman. So to recap the trial, in case anyone's interested, we have 2 cohorts. Cohort A is patients that are on melanoma receiving immunotherapy. These patients have high fermented food diets like kefir, sauerkraut, kimchi for 4 weeks. Then afterwards, we have them have a high fiber diet with high maize, certain fiber supplement for 4 weeks. Then we have another group, which is really focused on the fermented food findings where it showed decreased levels of inflammation. We want to see if patients that are experiencing those immune-related adverse events, so like cutaneous or rashes, if giving those patients either randomized fermented food high diet for 7 weeks or randomized fiber diet for 7 weeks, if that could improve outcomes. Yeah, so that's fermented food categories. And this is some kind of criteria. If anyone's interested, you can always talk after. And then if you're interested, you can always email Dr. Zaror or me. So that's kind of it. To recap, right now, some things that we could encourage are diet, always complement, not replace immunotherapy. We want to encourage a healthy diet, so high fiber, but high whole foods also. So some good guidelines are ACS or AICR, Dietary Cancer Prevention Guidelines. This is actually the specific guidelines that the MD Anderson study is using. And it talks about like diets low in sugar, diets low in processed meats, alcohol, diets high in whole foods, diets high in fiber like legumes. And then right now, fermented food seems promising, but evidence is still limited, which is why we're doing some prospective trials. And there's some caution, like fiber is context dependent. Be cautioned just with broad probiotic use. Really, if you guys have any questions, ask your oncology team. Then acknowledgements. Thank you, Drs. Rohr, Kako, who kind of also is a mentor, the whole lab, and then Dr. Devar, everyone else, and especially patients, families. Thank you, guys.
Ryan. Wonderful talk, and we have time for one question, not from the audience, but we have one online. What do we know about the impact of like different environmental agents like pesticides on the gut microbiome and how it would affect it?
Yeah, unfortunately that question's a little bit too broad, and I don't want to make any overgeneralized assumptions, but like we talked about,
Pesticide in particular, let's say, I think that was the like.
Yeah, I would assume that it has some obviously like detrimental effects, especially because of all the other things we know about pesticides, but I don't want to kind of say anything without knowing. So if they want, I could just follow up with an email to them.
And we actually, there's a lot we don't know, so that's why we're doing all these research. Great.
All right, thank you guys.
Yeah, I would also underline that, this study is an opportunity for you to do really very sophisticated research on that. So we very sophisticated approach to really evaluate the gut microbiome, looking at your blood, what these microbe produce, called metabolites. So we are doing a lot of things to try to better understand the impact of this diet intervention, right? So, and if we manage to show that this chronic inflammation is decreased, that will be a great opportunity to maybe expand this diet intervention in large cohort of patients. And the other maybe surprising approach, we didn't know our fermented food will be, because it's not very common in Western Pennsylvania, our patient would do it. And what we have seen so far, that the patient kind of like it, right? A little bit more sauerkraut or kimchi or, the most part yogurt and so on, or kombucha, that was easy. And in fact, as you see, you have another arm where we want to give a lot of fiber, and the lot of fiber arm is much more difficult. In fact, we had a lot of patients wanted to stop when they reach like 40 grams per day because of the bloating and everything. So as we move forward with this diet, we also learn from patients, right, what is feasible, what is acceptable, what is not, because in the end, if you want to propose a diet intervention to patient, it has to be something which is feasible, right? If it's for some reason not acceptable, there is no future there, right? And the high fiber in this regard has a lot of problem to solve, right? And based on what we have heard from patient. Okay, thank you so much, Ryan. So we go to the next talk. The next talk will be done by Dr. Ravi Patel, who is a radiation oncologist. So interesting by bringing into the equation of how to improve treatment of patients, in addition to immunotherapy, bringing the radiation as a way to ignite immune response when people are not capable of developing this immune response. So Ravi, thank you for talking to us.
Thank you for the opportunity to present a little bit about radiation therapy and the treatment of melanoma. When we talk about radiation, I just wanted to have a slide introducing radiation, maybe some people who are not familiar. So when we think about radiation, radiation is basically X-rays or photon, which is light. And that's majority of the radiation that we use clinically for patients. And it's delivered through a linear accelerator that rotates around a patient, and we deposit energy into them to cause damage to cancer tissues. There are also different types of particle radiation, such as electrons and protons. And then there's stereotactic radiosurgery, which we're using much more often. patients who develop brain metastases, we can use a gamma knife that can highly specifically radiate tumor lesions in the brain. There's a machine called CyberKnife, or we can use linear accelerated based therapies. This is a CyberKnife machine, which is a linear accelerator on a car robot. They can have multiple angles. And then there's also some brachytherapy approaches where we have a catheter that's put into a tumor and it delivers radiation locally. Historically, the use of radiation in melanoma has been limited. Melanoma is what we consider to be a radio-resistant tumor. So you need to deliver a lot of radiation to kill those cancer cells, and that could cause a potential toxicity to local tissues. However, newer types of radiation with the radiosurgery allows us to very precisely deliver those high doses of radiation. We can also combine it with immunotherapy to get stimulate an immune response. So radiation modalities that we use in metastatic melanoma, one of the common sites that it can go is into the brain. So we do stereotactic radiosurgery. And we're very good at controlling those areas that we treat, where we give a very high dose precisely, and it can take care of that area and limit that from progressing in that focal area. We also used stereotactic body radiation therapy. Sometimes disease can go into the liver, to the spleen, to a bone, and we can, again, deliver high doses of precise radiation to control disease in those areas. We also sometimes use radiation therapy in the palliative setting. Sometimes patients can have bone mets that can cause pain, or there's bleeding, and we can give radiation to palliate symptoms, and it's something that we often do in the metastatic setting. With stereotactic radiation, again, there's a few different types of devices, but this has been a big advantage over more traditional radiation that we used to perform. So previously, when patients develop brain metastasis, we would give whole brain radiation. We can see we're radiating the whole brain, not just specifically finding each tumor and radiating them. And this has cognitive side effects where patients can have forgetfulness, their abstract thinking ability can decrease. On the bottom, we see our stereotactic radiosurgery, where we identify each lesion, and we see a lot less of the brain volume is given high doses of radiation. And several studies have shown that these stereotactic radiation treatments can preserve cognitive function while controlling tumors well. We can also give radiation therapy for extracranial disease. There was a study done up in Canada called the Sabre Comet study that showed in patients that had limited metastatic disease, we can give stereotactic radiation that can achieve good local control, but also improve survival. Sometimes these stereotactic radiation treatments can also help consolidate a treatment. Many patients, they respond to immunotherapy, but there can be one resistant lesion that's growing while the rest have responded, and we can kill those resistant clones with the stereotactic radiation. On the right, I have a couple examples of a patient who had a liver metastasis. Their disease elsewhere was controlled, and we were able to take care of it with this external radiation. And same things with bone metastases. We can give palliative radiation as well. These are typically short courses of radiation, either a single treatment, or sometimes we do up to 5 treatments. If patients develop cord compression, it can help prevent further damage to the spinal cord. It can help if there's subcutaneous disease causing pain, it can help relieve pain, and also bleeding. And these are much simpler kinds of radiation where we can get these treatments started quickly, often as an inpatient as well. So in melanoma, there's been a lot of interest in using radiation to stimulate an immune response. And there's this term coined the abscopal effect. It is from the 50s. There was an observation that when a patient had radiation at one site, there was a systemic immune response at other sites of tumors. And then there was this study, a case report really, in the New England Journal in 2012, where a patient with melanoma was being treated with ipilimumab or anti-CTLA-4, and they were progressing, but then they got radiation to a single site, and they saw responses elsewhere. And this was a historically rare effect, but this renewed this interest that if I give radiation to stimulate an immune response, can I make immunotherapy work better? Radiation has several hypotheses of how it can help overcome immune escape. So radiation can kill cancer cells, exposing tumor antigens. It can cause immune cytokines to be released. It can also kill off suppressive immune cells that can prevent the immunotherapy from working as well. It can potentially lead to antigen cross-presentation and an improved T-cell response. There's been preclinical studies, and this is a bit older study in melanoma, where they showed that there was a tumor that's resistant to anti-CTLA-4 and anti-PD-1 immunotherapy, but if they gave radiation, there was an improved response. And they showed that they can increase the diversity or the different types of T cells that are present in the tumor, as well as potential clones that can recognize the tumor. And so they hypothesize that radiation can work in situ vaccine. There's been several trials, a few in melanoma, but also in other cancers, where they have tried doing this approach of giving radiation plus immunotherapy. And unfortunately, we're not seeing in patients what we see in our preclinical models, where we irradiate one site and other sites respond. There is some response, but just not the complete responses we're seeing it preclinically. So when we look at the effects of radiation, radiation, like surgery, is a local therapy. Many of the effects may be present in the tumor microenvironment that we irradiate, but not at those distant sites. So we ask the question, can we deliver immunostimulatory radiation to all sites? So that's difficult to do with those external beam radiation techniques that we conventionally use. But there's a type of radiation where we have a targeting molecule, and to that we attach a radioisotope. And it's been used in thyroid cancer since the 50s, but we really haven't had new agents until recently. And this is a way we can deliver radiation in patients with metastatic disease. The barriers to clinical use have been that it's hard to get a therapeutic index. As I mentioned, melanoma, we need to deliver a lot of radiation because it's a radio-resistant tumor. So we're also going to be delivering some radiation to normal tissues when we give systemic radiation. So we may not be able to use just these radioisotopes alone in a disease like melanoma. There's a patient example on the bottom left, where we see a patient with widely metastatic prostate cancer. They were given these radioisotopes and had a pretty impressive response. But we're not able to do that for all cancers and all diseases. And so we were wondering, can we give a lower dose of radiopharmaceutical therapy with immunotherapy to improve our therapeutic index? So we did a study in preclinical models that are resistant to immunotherapy. And what we see is that if we give radiation alone or immunotherapy alone, we don't have much of a response in these preclinical tumors. But now if we give this combination, we see in the green and black lines low that we prevent those tumors from growing. And we had about 2/3 of the tumors go away with an extension in survival. We also looked at the tumor microenvironment when we took these tumors out. And we see that with just the radiopharmaceutical therapy or immunotherapy alone, in these fairly cold tumors, we don't see much cytokine activity. But now when we give this combination, we see much higher levels of most cytokines in the tumor microenvironment, with the exception of IL-10, which is sometimes a suppressive cytokine. There's quite a few of these radiopharmaceuticals that are being currently tested or being developed in melanoma. B7H3, anti-GD2, which is a antibody-based target present in neuroblastoma as well, but is also being tested in melanoma. There's some agents targeting the melanin pigment in melanoma, and a few different agents. And we also here at UPMC do have a current phase 2 trial of agent targeting MCR1 in combination with immunotherapy that we're accruing patients to. So some future directions and emerging strategies. We're still trying to optimize radiation dose and fractionation for immune priming for radiation immunotherapy treatments. We also need to figure out how we can deliver this radiation to all sites. So potentially radiopharmaceutical therapy can be a good avenue. People are looking at proton and flash therapies that reduce the integral dose to all regions, causing less immunosuppression. I mentioned these radiopharmaceuticals, especially alpha emitters, that can deliver a very high dose of radiation, even to radio-resistant tumors. And then these combination trials of radiopharmaceutical therapy plus checkpoint blockade and biomarkers. Thank you.
Any questions from the audience? All right, we have one online already. So this is a specific example, but just to have a broader view. In the care of patients with melanoma, is radiotherapy considered a standard of care when there's like involvement outside of the brain? And a specific example that's been mentioned here is, do you also use immunotherapy agents in conjugation with radiotherapy in those instances where we have systemic involvement, basically?
Yeah, so I don't think radiation therapy alone is a standard of care for metastatic melanoma. Radiation therapy is a targeted therapy, so it can help with local control. If there's a single area growing on the skin, they can remove that surgically, right? If it's inside the body, it's a little bit harder to do surgery there. And radiation therapy is used to control disease in those sites with immunotherapy. So I don't think we have the data that it's standard of care that every patient with metastatic disease should be getting radiation therapy.
So Ravi, a question for you also. Can you comment on the because there's the different flavor to radiotherapy, right? You can give big dose to decrease the tumor, but now, based on what you explained us, the goal is to help the immune system. So what does it mean in terms of what type of radiation is helpful to achieve this goal?
Yeah, so there's actually emerging data that low doses can cause stimulation of some types of cytokines and cause immune stimulation, but then also the higher dose radiation can cause more antigen release and immunogenic cell death. So we call that heterogeneous dose, where we get some effects from lower dose, some effects from higher dose. And so these SBRT treatments, actually, we can give both high dose and low dose to try and take advantage of both of those effects. And they can stimulate the immune system in different ways. And so I don't think we have a final answer, but we do have data that either one could potentially be helpful.
Okay, and what are the consequences in terms of the patients? There's a side effect and...
Yeah, so with the types of radiation we're giving now, especially with stereotactic radiosurgery, we have really small margins of the high dose area. They're within 3 millimeters or so. So we often can limit side effects pretty well when we give radiation therapy these days. Definitely when we give large fields. So if a patient has a head and neck melanoma where we're giving our conventional fractionation 60 grade, there's a lot of side effects. We're giving 30 treatments or so. We cause mouth sores, get dry mouth, salivary function. But with these stereotactic radiosurgery treatments, we really are limiting our side effects into 5 or even 3% or lower range for the most part.
Very good. Thank you so much. So we're going to go to the next talk, which is going to be presented by Catherine Heike. What do you need to know about sunscreens? Thank you.
Thank you. So I'm going to talk to you guys today about what you need to know about sunscreens. So this is our agenda, what we're going to cover, your skin types, the anatomy, UV radiation specifically, types of sun protection, and public health measures being taken to hopefully reduce the risk of future melanoma patients. So first things first is when we meet you in clinic, we are phototyping you. We have found that the higher risk patients tend to be our type 1s and type 2s, although all patients, no matter your skin phototype, tend to be at risk of developing melanoma. This scale specifically was developed by Dr. Thomas Fitzpatrick to help us classify skin types and determine who is at a higher risk of developing melanoma. The type 1 and type 2 patients tend to be those patients that burn very easily, may fade to a tan over time, but typically freckle. So a lot of our patients fall in this category, but like I said, we do see a little bit of every skin phototype. So skin anatomy, we know that the skin is made up of 3 layers. The top layer is your epidermis, the middle layer is your dermis, and the lower layer is your hypodermis. Melanoma specifically originates in the melanocytes, which is found in your epidermis. And as you can see in the photo to the right, so we typically stage melanoma. One of our major mechanisms of staging is the Breslow depth, which many of you have become acquainted with as you've been diagnosed, and it grows vertically into the skin layers. Melanoma is typically caused by variations of UV exposure, although there is a very small category of patients that are genetically at risk. Most of our patients are usually from UV exposure. So what is UV radiation? UV radiation is considered a complete carcinogen due to its ability to mutate, and it's a non-specific promoting agent. This means that radiation can be a tumor initiator and promoter, most commonly known to all of us in our outdoor settings. So sun exposure is one of the ones that we know most commonly, but a lot of patients are also, we are exposed on indoor environments as well, but specifically our most at-risk population is those who have used tanning beds, because that is increasing your risk of UV exposure exponentially. Prolonged UV exposure can be whether you're sunbathing in a tanning bed, whether you've developed sunburns, which can include redness, pain, blisters, and swelling. Prolonged UV exposure can also contribute to photoaging. So a lot of patients, if you are worried about your appearance, avoid the sun if you can, or protect your skin so you don't develop early onset wrinkles, loss of collagen, and other early aging. We are specifically worried about your increased risk of skin cancer when you are exposed to UV radiation. These are just a few of the skin cancers we follow, but we're going to talk about the melanoma. So when to wear sun protection? We actually do recommend that you're wearing sun protection all day, every day, but specifically we want you to wear it no matter of your skin phototype. Like I said, we're all at risk of melanoma, although our higher risk populations tend to be those fair-skinned. All individuals should be wearing it on sunny days and cloudy days. We do recommend you apply it about 15 to 30 minutes before you enter the outdoors, but also before you put your clothing on, because we know as it's drying, your clothing may rub it off. Other things I found while looking into this further is if you don't own the UPF clothing that we typically recommend, that as people ask me, they say, is that the clothing with SPF in it? Yes, that is what we call the protective clothing. But I've also found if you have newer clothing that is cotton, polyester, and dark colors, not stretched, worn out, or washed many, many times, that also provides you with some UPF protection. Your peak sun is 10 a.m. to 4 p.m. We do also recommend, even if you're skiing, wear your sunblock because UV rays can reflect off snow, water, and sand. So if you're at the beach and you're in the shade and you're still getting burnt, probably because it's reflecting off that water or the sand. We do recommend you're reapplying your sunblock every 2 hours in the sun, every hour in the water. So if you're sweating or swimming, reapply. A lot of patients don't know how much. They think a thin layer will be enough. We actually recommend applying I won't go over each one, but it's quite a generous amount. If you think it's enough, apply more. So other things that I have recommended to patients is when should you apply it? If you're ever in doubt, look at your phone. In the weather app, there's a UV index. If the UV index is 1 or more, apply your sunscreen. So types of sun protection, as I was mentioning, we have mineral sunblock, which is what we like to recommend, but there is also chemical sunscreens. If you are getting any type of sun protection, we always recommend an SPF or more, 30 or more. We wanted to say broad spectrum because it protects against the UVA and UVB rays, which both can penetrate the skin, damage those cells, and promote development of melanoma. Water resistant, and this is why we recommend reapplying every hour in the water. They only can last up to 80 minutes, and that is if you apply an adequate amount. We definitely recommend checking those expiration dates because even though you think you're properly applying, there is still a chance that it is not protecting you like it should. And then the UPF clothing, like I said, it is a great additive protection against the sun. But also, if you don't have UPF clothing, please be sure to wear those darker colors and newer clothes so that you are having that added protection. We also recommend wide brim hats and sunglasses. I have found that I don't love wearing hats, but they do also make UPF headbands that you can wear. So if you are out and about and you want to protect your part, because many of us forget to apply sunscreen to our part, wear those headbands. So what is the difference between chemical sunscreen and mineral sunblock? We'll start with the chemical sunscreens. Those ones you tend to, when you apply, it absorbs the UV rays, UVAs and UVBs. It converts it to heat. It's absorbed into the top layer of skin. Takes about 20 to 30 minutes to activate, so must dry. And then these are the chemicals involved in that protection. Mineral sunblock tends to scatter, reflect, and minimally absorb those UV rays. It creates a barrier on the skin. It does not absorb into the skin, and it does tend to provide more immediate protection. The ingredients in that, I always say, if you have zinc, great. If you have titanium and zinc, even better. Both of these sunscreens or sunblock is better than nothing. So if you are torn between the two, something is better than nothing. But we do typically recommend the mineral sunblock because it creates that barrier. It does not allow those UV rays to penetrate and damage those skin cells. But a lot of patients are struggling to motivate themselves to apply it because it leaves that white hue. My new recommendations to patients is trial and error. Don't go and buy the big bottle. Find what you like, try it out, and then figure out what works best for you. So across the country, there are many organizations that are making a public health effort to reduce the risk of sunburns because we know that the buildup of UV damage over time leads to melanoma. These are a few of the organizations I have found. Impact Melanoma is placing free dispensers all over the country at local parks and different areas where patients can access free sunscreen. Melanoma and the American Society of Dermatologic Surgery are both reaching out to different sponsors to then set up their own sunscreen dispenser, and they are in charge of replacing that sunblock so that you can have better protection. So it is more available to patients across, if you forget it, if you're out at the park with your kids, it's there to protect yourself and your family. These are just a few of the references I've used to provide these recommendations for you guys today.
So we have a question there. Great. Make sure.
I was just going to do a more general question, like with the mineral sunblocks, is there a few brands that you would recommend, like maybe people start with, like that have been like super popular? I know Blue Lizard is one of the big ones.
Yeah, a lot of patients know Blue Lizard. It, I believe, was one of the first mineral sunblocks to really be publicly known, very available to patients. It's affordable. There are many sunblocks available. I recommend just going up and down the aisles, whether you're at a local pharmacy or one of the big chain shopping stores. Look for mineral sunblock. The label's on the front. Flip it over, make sure it says zinc plus or minus titanium, as long as it has zinc. And then that is adequate enough. It doesn't need to be a specific brand. Just look for the label of mineral sunblock on the front. Find that sunblock that provides that barrier and protection for you.
Great. Anyone?
Hi, Katie. So let's say I was gonna go play golf. So I'm gonna be out there straight in the sun for like 4 hours. So if I use SPF 30 versus like SPF 70, can I reapply later if it's the 70, or is it the still like 2-hour window?
It's the same recommendation no matter the SPF you use. I do have a lot of patients that also ask, well, can I use the spray? Sure, you can use the spray, but what I did find in my research prepping this presentation is they say the amount of spray you need to use is about the size of one shot glass, which we are all quite aware. So the amount of sunblock you should, yeah, we're all familiar with the size of a shot glass. If you're applying that much spray sunblock each time, they said it's about 6 applications per spray bottle. You should be spraying it on your skin, rubbing it in, and then still reapplying every 2 hours. So it is a lot of spray sunscreen, which is why we tend to recommend the cream and then using that teaspoon rule. If you're using it on children, most children sunblock does incorporate mineral. They don't have the option for chemical. So that is another thing that I think is important to note. So if children are only recommended to use mineral sunblock, I think the rest of us should be. And same thing, their skin should be glistening and appear wet if you are using spray sunblock rather than cream.
Great, great. And we have 2 questions. We have one more too. Okay. So just to touch on the 2 I already have, is there a way to safely tan? And another one is there any evidence that certain chemicals in our some of our kind of like sunscreens may actually cause cancer itself by getting absorbed through the skin and making some DNA damage?
So there is no safe tanning whatsoever, whether it is sunbathing outdoors, in the tanning beds. Tanning beds have 13 times the amount of normal UVA rays that we know penetrate the deepest in your skin. So no amount of tanning bed use is safe. In fact, the doctors I work with, we feel that it should not be legal and open to the public because of the amount of risk it puts you at. These young people are tanning and it is putting them at risk later down the road. Now, chemical sunscreens, we do know they can absorb into your skin. We do know that eventually it may pose a risk, but the risk of that absorption does not outweigh the benefit of the protection. So if you are worried about it absorbing into your skin and causing a hormonal imbalance, because I know there are questions of that out there, I don't think that's the case, but if you are concerned about it, use that mineral sunblock. It doesn't absorb into the skin, it protects you, and then there's no concern.
And we're about to time to wrap up, but one last question that just came in. Is there a difference between American and European sunscreens? Any particular data on that?
I didn't look into the European sunscreens as much. I do know that there is some differences. I don't know. Dr. Kirkwood has an answer.
European sunscreens that are just not available in the US. And that's a known difference. The FDA has just not approved them, and that's been already for many years a difference between what are available in Europe and in the US.
So as a dermatologist, practically in my practice, I would say two things. The first thing I have, so patient always know what best sunscreen, what should I do? And there is always a focus on how strong the sunscreen is, right? Which is important, but I think above 30, everything is okay to me. I think the most important thing is the reapplication, right? So all this sunscreen have been tested, as you said, putting tons of it, right, on the skin. That's what we do in practice. People put less of that. So I think on a regular warm day, after a couple of hours, your sunscreen is going to be gone. So you need to reapply it, right? And that's and people don't do that. A lot of people put that once in the morning and believe they are protected. So my focus when I talk to patients is say you need to apply every 2 to 3 hours. The second point I think which is important is using sunscreen, even if they protect you, is not a license to continue exposure, right? So this is just to help limiting the exposure in the context of moderate exposures. Meaning you don't have to spend hours, in a swimming suit the whole day at the beach, or you don't do that, right? You try to limit this exposure. You use clothes and t-shirt if you have to spend there at the beach or a swimming pool. It's not that you wear a sunscreen and you spend 10 hours a day. I think that's defeat the purposes, right? This sunscreen is a part of the sun protecting methods. Moderate sun exposure is also extremely important in general. Good.
Thank you.
Okay, thank you. So now we are getting to the closing remark of this great day. But I would like to thank first all the speaker, right? All the team, the speaker for this great event that we have annually. I would like to thank Dr. Kirkwood, right? That without him, we won't be here. Right? It takes 4 decades for him to build this very strong program to help you, right? To provide a patient in Western Pennsylvania the best care. And build an outstanding team of investigators. You have seen this great oncologist, great PA, great nurse here, all this team working tirelessly to meet your need, to answer your question, to help you, on your journey when you have melanoma and have to face a very difficult decision. And I'm very proud myself to be part of this outstanding team. So we have heard also that behind the curtain, you have also a lot of researchers, right, who are working also to help you, right, developing the new stage of treatment. So thank you. Of course, the patient, it's great to have you every year. Hear from you. We need to hear more from you. And thank you for John Kirkwood and Lisa to organize this symposium. And you have many opportunity to talk, right? When you see your oncologist, we want to hear from you. We also organize many events. Beside this, there is a melanoma walk coming very soon. So hopefully you are able to participate to this walk and have the opportunity to talk to the treating team. I think we're going to all to be there and want to hear from you, right? And finally, I would like to thank very much Lisa Huntley, right? Lisa is John Kirkwood admin, and Lisa very modestly and but tirelessly spent tons of effort organizing this session, all the event when we hear from you, meaning she does amazing work. She never complains, right? And she's doing an amazing work. So Lisa, without you, we wouldn't be able to do all that. So I would like to thank you on behalf of everybody. So I will now it's also beside the patient directly, the association, the patient advocates are very important. And AIM at Melanoma is really playing a critical role here. So I would like to introduce for the closing remarks, Arngard Taylor. Thank you to all.
Thank
Thank you, Dr. Zaror. Thank you to everyone who attended today. Thank you to Hillman Cancer Center for another wonderful symposium. They have been a friend to AIM at Melanoma for a very, very long time. Thank you to Dr. Kirkwood and Dr. Zaror for leading the charge. And thank you to our panelists for what I thought was some very exciting research that is coming from this cancer center. So I know that that was exciting to all of us to hear what's coming forward. For those who don't know AIM at Melanoma, I'd like to tell you a little bit about our organization and what we are doing as patient advocates in the melanoma space. It starts with Valerie Guild and Charlie Guild. 20 years ago, Charlie Guild was diagnosed with melanoma at the age of 25. She passed away. And her mother, Valerie Guild, formed AIM at Melanoma with two purposes. One was to find a cure for melanoma. And in that space, we do two things I'd like for you to know about. One is that we established the International Melanoma Working Group, which is a group of 45 international melanoma researchers who gather twice a year to collaborate and communicate with one another. And Dr. Kirkwood is one of the co-chairs of that group. So thank you very much, Dr. Kirkwood, for your work in that. The other thing is we established 5 tissue banks where we collect fresh frozen tissue from the primary tumors, and with its, the purpose of that being is to be able to give that tissue to researchers so that they can find this cure, move the needle forward. And just this year, we have our first proof of concept application that has come in. And so we are extremely excited as we, are able now to take that work of accumulating the tissue and move it towards researchers. Secondly, and the other half of our mission is to support people who are living with melanoma from the time of diagnosis all the way through survivorship. And that support comes largely through our website and through education that we provide. And all of it is free to the public, and I'm going to take just a minute to tell you a little bit about that. By far, the most frequently visited pages have to do with treatment and, with staging, related treatment, side effects, side effect management, and clinical trials. And so I invite you please to come to our website. Most of us are not clinical. We don't have a background that is clinical. And so we intentionally write this information. This information is presented in a way that is understandable to the public. We also have a wonderful service that's called Ask a Medical Expert. Melissa Wilson from UPMC is our medical expert. Thank you, Melissa. She has a form online. I want to say to those, especially those of you online, there have been a number of questions that have come in today that I know that we have not had the chance to answer. But Melissa has a form and she would love to answer your question. And I've put that link into the chat for you. And so Melissa's not going to change your plan of care. She's going to help you to understand your plan of care. But the other thing that Melissa does is she is a YouTube star. She has a webinar series called From the Clinic to the Living Room, where she's taken a number of these most frequently asked questions and answered those questions for you. So I invite you to go and look at those webinars, wonderfully, wonderfully presented. We also have a podcast called Beyond the Clinic, Living Well with Melanoma. Our host name is Dr. Samantha Siegel. She is the Director of Survivorship for Kaiser Permanente. On that podcast, what we talk about are not the physical challenges, the clinical challenges of melanoma. It's the emotional roller coaster that often accompanies a diagnosis of cancer. And so we invite you to listen to those. We talk about things like building a support network around yourself or dealing with unwanted invasive thinking, how things like yoga or journaling can be useful to you during that period of time. Dr. Siegel herself is a cancer survivor, and so she brings a lot to those discussions, and I certainly encourage you to listen to those. Those are monthly podcasts. And then, of course, we have 10 symposiums a year that we co-host along with cancer centers all across the country. I want you to know what we will do with this wonderful information. What we do is we take the presentations, we edit them, divide them by topic, and we put them back on our website so that you can watch them again. Unless you took, stenography when you were in college, I think you'll probably like to watch it again and, in your own home, or share it with your family so they will understand more about melanoma treatment. I want to give you an example of something, though, that we do with this information. We're not just a bunch of pretty faces now. We listen too. And last year, Dr. DeVar's presentation just had me absolutely gobsmacked. I was so interested in what we know now about the diet and its impact on immunotherapy. So we asked him for his research. And we now have a page on our website about his research, but we also have a sample 5-day high fiber meal plan that we put on there for individuals who come to our website. So this is an example of how, like you, we're learning, and then we make sure as advocates that information is available to you. We have a section on caregiving. We know how important caregivers are in this process, and we want you to take care of not only the person you love, but yourself as well. And lastly, we have a program called Peer Connect. Peer Connect is a one-on-one mentorship program. I have over 50 individuals who have stepped forward to serve as their former patients who have completed their treatment journey. They have stepped forward to serve as sources of inspiration and encouragement to people who are going through the treatment journey. And just this last year, we also started an adjunct portion of Peer Connect for individuals who are considering TIL therapy. If they want to talk to somebody about, things I wish that I had known or need to know before I embark on TIL therapy, I now have TIL therapy Peer Connect mentors as well. Dr. Zaror already talked about the Steps Against Melanoma walk that's coming up here in the Pittsburgh area on May the 9th. I want you to know that the funds from these walks, they fund that tissue bank that I talked to you about before. So not only is it important in terms of the money that we raise because it's working towards a cure, but also it's an opportunity to get together with people who understand the journey of people who are going through melanoma and to raise awareness about sun safety. So thank you so very much. If I can answer any questions or direct you, I'm the navigator of the huge website that we have. Please feel free to reach out to me. And lastly, there's a survey that's both coming to you online and also in your packets. I'd appreciate if you'd fill that out. We do a much better job putting on these symposiums if we know what's relevant and important to you. What did you find interesting? And so if you'll fill that out, I sure would appreciate it. And with that, Dr. Kirkwood, do you have anything you want to say? No, he says no. He says we can go home. So with that, thank you so much. Have a good rest. Oops, I have a question. I've never had a question. Yes?
Just put it all over our bodies and taking melanoma. I think it was so stupid, but there was never any talk about it. So it's anyway, but I'm doing better. But yeah, baby, it was like we were frying ourselves.
Okay. All right. Have a good day, everyone, and thank you. That one.